and became 6 millimeter. So, well, of course, CT is important in the normal functioning of the prostatic valve. We usually assess the opening angles like this, should be like around 7 and then 8. Okay, and it should be like this. But if you feel an obstruction is diagnosed. The second case is an 18-year-old lady. She has a history of VSD repair, 2005, a history of metallic mitral valve replacement in 2008. She is on warfarin. She complained of shortness of breath and chest discomfort and fainting. The echocardiogram showed ejection fraction 55. Prostatic mitral valve is well seated, but the peak gradient, the mean peak gradient is increased to be 18 with increase in the RV systolic pressure. Hopefully, it will work, inshallah. And you can see here that this is not working. You cannot really assess it that well, but you can see that there's a lot of ileusing in the diastole. Again, the report was like this, and need urgent fluoroscopy or CT to rule out aortic a stuck valve or something. Bismillah. So fluoroscopy was done, and it was reported to have partially stuck mitral valve with one of the leaflet moving and the other one not moving correctly. However, due to the poor visualization, try to confirm this with TE and cardiac CT. I copied the report as reported by the interventional cardiologist. So in cardiac CT, what did we find? We found, like here, again, the opening angle is distorted. They're not symmetrical. But you can appreciate here that there's something here like a calcification on the ventricular side of the prostatic valve here. And this is on the 3D rendering. You see like it has like two calcifications that are hindering the opening of the valve. The report said that valvular pannus with an area of calcification resulting in restriction of the anteromedial mitral leaflet, and also the VSD was known, and so it was diagnosed to be a pannus. So one of the key parts of CT is to differentiate between a pannus and a thrombus. Of course, it's the time frame. Pannus, long time. Thrombus is usually recent. The clinical status, acute and versus subacute or chronic. The valve, usually pannus is more on the mitral, while the thrombus is on the tricuspid mitral, and then the last is the aortic. And of course, the morphology, if it's small and dense, because it's mass made of fibrin, or is it mobile and large and density? And the most important part and the most crucial role of cardiac CT is in the Huntsville. And so if the Huntsville unit is greater than 145, more with the pannus, while if it's less than 90, or more than 90, I'm sorry, and less than 145, this is suggestive of a thrombus. So multi-slice CT is not the first, but it's the appropriate next step when you have an equivocal echo, especially like in these two cases, when there's even suspicion of an equivocal fluoroscopy. It evaluates the mobility, the extent of the limitation, how much is obstruction, how much is the Huntsville unit of this mass, if there's any leak or regurgitation, if there's any paravalvular leak, and of course, if we're going to redo surgery, it will give you information about the coronaries and the anatomy of the valve. Post-TAVI is an important part to be evaluated with cardiac CT, especially if there is subacute thrombosis of the valve, which is a real thing in post-TAVI cases. And of course, cardiac CT plays an integral role in this diagnosing of this disease. One of the other most important clinical scenarios where cardiac imaging is important in prostatic valve is in the endocarditis complication. So this is one of our patients. You can appreciate here that she had a 36-year-old male with fever and positive blood cultures. You can appreciate here is the aortic valve. It's well functioning, but there is a pseudoaneurysm, and I hope you can appreciate it here, which is opening because he had an aortic root abscess, and now it has a pseudoaneurysm opening into the LVOT area. Again, this is a similar case with the same outflow, pseudoaneurysm here. So it is projected that in cases of prospective infective endocarditis, you look, as we clinicians do, using the Duke criteria, and then if it's definite, khalas, then we diagnose it. But if it's possible, then you could consider further imaging by cardiac CT, and even consider PET or PET CT if you want to see if there's area of inflammation and infection. So cardiac MRI and prostatic valve, does it have a role, or is it really contraindicated because this is a prostatic structure? Cardiac MRI has the important diagnostic tool in accurately evaluating flow and accurately evaluating volumes. Of course, these are images from the Methodist Hospital, and you can appreciate here, this is a TAVI case, status post-TAVI, and here we can see here that on the flow there is paravalvular regurgitation. This is what we can see using the cine. But most important is that by calculating the volumes, you can accurately calculate the regurgitant flow volume so that if you need to redo the surgery or something else needs to be done. Again, also here, this is a prostatic mitral valve. It is still safe in cases of to go to CMR. And here you can evaluate the forward flow and the regurgitant flow, and accurately evaluating the regurgitant flow fraction by cardiac MRI. How do we do it? We do the flow here at the aorta, and then we calculate the flow across the mitral valve. So CMR is a useful complementary tool. It is safe in patients with prostatic valve, both mechanical, bioprostatic, and TAVI at any time after implantation, because the field that we're using is about 1.5, maximum 3 Tesla, but there's no risk of dehiscence or something bad happening to the valve. Of course, you always have to double check the same MRI safety by going to the mrisafety.com website to ensure that this valve is MRI compatible. It's got limited value in cases of morphology, diagnosis, vegetation. Vegetations are small and mobile. You cannot evaluate them very well by cardiac MRI, but it's usual. Its most important role of cardiac MRI is in the quantification of prostatic valve regurgitation, volume, and fraction.
2 minutes left, yeah.
Yes, I'm almost done. And this, of course, this is the flow that we know how to evaluate the prostatic valve. Because an accurate evaluation of the regurgitant flow is important, and that is why here they say put CT and cardiac MRI is included in the algorithm. So in assessing prostatic valve function, of course, you have to evaluate using the echo, using the TE, but CT is important in evaluating of the valves, the opening and the closing, and if there's pannus or thrombus. Cardiac MRI gives you very good information regarding the flows and the volumes, and hence calculation of the regurgitant fraction. If you are suspecting infection, you can do PET CT or gallium to evaluate the infection of the patient. And this slide really depicts how useful each and every one of these techniques are. And as you can see, they are really good complementary tools to our basic echocardiogram, because this is the basic, easy, non-ionizing and bedside technique. And thank you for your time.
Thank you so much, Fatma. You can come here, please. We are lacking behind, but we can take like 2-3 questions to the Dr. Osama. And this Professor Muhammad is us here, Shabab. Prof. Muhammad is us online. Assalamu alaikum. Okay, so please, if you have any questions, quick question, because we are lacking behind really. دكتور ريم عندك أي سؤال
I'd like to thank all speakers for beautiful talks and very specifically the last talk. My question goes to Professor Muhammad Ayman. The point of care, I don't think this is addressed for cardiologists, right? We are trying to let non-cardiologists get partial training in doing quick echo. Is this one of the messages? Yet they have to go back to a cardiologist because we're seeing lots of abuse of the point of care in pediatric cardiology done by non-cardiologists. It should be only for basics, but the detailed echo should go for a specialized person. Please correct me.
كومنس بشوية كده منا Thank you very much. Just a few comments. Actually, in our hospital now, they are planning to give like 1 or 2 POCUS machines to the on-call doctor and to be indoors from shift to shift with the pager. So just a quick comment to Dr. Osama case. I don't think this is the left atrial appendage, right atrial appendage aneurysm because it is away. I think it is near the tricuspid valve, even distorting a little bit. It is a little bit away from. I think it is just the verticulum of the free areole. I think so. And just last comment to Dr. Fatma. In our hospital also we stopped doing really this fluoroscopy for the stuck valve. We do either CT and T because within 30 seconds can give you the answer, full stop. In fluoroscopy you need to do like 360 rotation to take the valve from all angles. I think we should stop here because we should move to the next session. Because we are lagging behind. Thank you very much for all of you.
Just to honor Dr. Haytham. Remind the people who want to share the journey to put his outside because we'll select from this the 3 teams. It will be 3 teams. Each team will compose of the 3 doctors. Okay? So don't forget to put your name outside.
كلهم consultant fellows كلهم ممكن يشاركوا. طيب انا وين
بسم الله الرحمن الرحيم والصلاة والسلام على سيد الخلق والمرسلين. Good morning, ladies and gentlemen. Thank you very much indeed, Dr. Professor Rima. I think this is a beautiful introduction. And thanks for Dr. Ala for giving me the opportunity to be with you today. Now, I'm going to talk about aortic stenosis beyond gradients. Now, since the days or drawings of Leonardo da Vinci in 1512, there have been tremendous achievements in the diagnosis and treatment of aortic stenosis. Now, aortic stenosis is very common and the most common valvular lesion in the Western Hemisphere, and it is mostly there due to sclerotic aortic or calcific aortic stenosis. In this part of the world, it is mostly due to rheumatic heart disease, in addition, of course, to sclerotic heart disease or aortic disease. Now, mortality increases with all grades of aortic stenosis, not only severe aortic stenosis as it used to be in the past, but it's also with all grades of aortic stenosis. This is a study which was published in January 20. I think this is not working, unfortunately. This is a study which was published in January this year, and it showed that there is very good correlation between the Vmax, or the velocity of the aortic valve, and the all-cause mortality. And this is one of the new things, not only in severe aortic stenosis. Now, with the advances in TAVI and wide experience with it, of course, we need many modalities to get to the diagnosis and accurate selection of patients with aortic stenosis going for the TAVI. Now, still up till now, transthoracic echocardiography is still the gold standard imaging modality for the assessment of aortic stenosis severity. This is December 2022. And when you get a case like this, with the peak gradient of 141, mean of 80, and area of 0.4, 0.5, this is a straightforward case that this is severe aortic stenosis. There is no problem with such cases. But of course, there are other cases where actually it can be more problematic. I have to stress a point here that to make a precise diagnosis of aortic sclerosis, when the gradient on the peak velocity is less than 2.5 meters per second. Beyond that, we talk about mild aortic stenosis or moderate aortic stenosis, and so on. Now, the aortic valve area, sometimes we may have to do it by planimetry, whether on transthoracic or on TEE, and that's slightly different from what we derive by the continuity equation. Continuity equation gives us the effective orifice area. This is the anatomical aortic area or geometric aortic area, and we all know how to calculate the aortic valve area by continuity equation. I think this is straightforward, and the machine does that automatically. Now, still, actually, the guidelines and the definition of severe aortic stenosis, when the aortic valve area is less than 1 square centimeter, and the mean gradient greater than 40 millimeter mercury, or jet velocity greater than 4 meters per second, or 64 millimeter mercury. Now, the same is still reiterated in the latest European guidelines in 2021, so there is no change in such definition. Now, I think there was some people still actually underestimate the gradients by not picking up the right area to get the gradients from. And it has been shown now for almost 10 years that the right upper the right parasternal window is the most fruitful for getting the proper gradient. It's more efficient than the conventional apical view. Now, there is actually, we just heard about the handheld echocardiography, and this is in December 2022, that it has been shown actually to be useful because they now incorporated the continuous wave in it. And now this is what we obtained, or what they obtained from a conventional machine, and these are the velocities or jet, excuse me, obtained by the handheld echocardiography. So I think there is actually comparable view, and I think it is reasonable, a very reasonable correlation. Now, when we talk beyond the gradients, let's start looking at the anatomy of the valve, not only just looking at figures and gradients. So we have to look at the anatomy, and this is a classical example of a patient with rheumatic valvular stenosis, rheumatic aortic stenosis, and that's a case of a sclerotic or calcific aortic stenosis. And there are differences between the two. Now, with calcific aortic stenosis, we got nodular calcification on the leaflet. There is no commissural fusion. You can see the commissures here are completely open. To the contrary, with rheumatic aortic stenosis, we get commissural fusion, as you can see here, and this is actually a characteristic about rheumatic aortic stenosis. One important point when we are looking at the aortic valve is to try to avoid the calcification when you are measuring the aortic valve annulus. This is very important because that can affect, of course, the aortic valve area. There is in 2023 now in JACE this month, there is actually a novel application of 2D calcium quantification method, and this is a software in the machine where it measures the mean pixel density of the entire valve in relation to the mean pixel density of the annulus here. And this is actually, it shows the ratio. When the higher the ratio, the worse the aortic stenosis. This is a mild aortic stenosis, moderate aortic stenosis, severe aortic stenosis, and they have been shown to have moderate to strong correlation with such calcification. Of course, CT scan plays very important role in the assessment of patients with aortic stenosis before selecting the patients for TAVI. But still the effective orifice area is the method of choice because it has been shown to have better correlation with the clinical and functional variables than the geometric area. But this is actually in patients with bicuspid aortic stenosis here, and that's December 2022. Some people forget to add in their report the dimensionless index, and that's very important, particularly when you are dealing with a prosthetic aortic valve. And this is easily taken by just determining the TVI, or the peak velocity of the LVOT jet here, to the peak velocity of the aortic jet. And the ratio, if the ratio here is less than 0.25, that indicates a critical aortic stenosis. Now we move forward to other measures, other parameters, and this is in November 2022. The importance here is shown of getting the acceleration time. Sometimes we forget to measure the acceleration time, and this is quite helpful in differentiating patients having pseudo aortic stenosis from true severe aortic stenosis in patients with low flow gradient aortic stenosis. And the best cutoff value of acceleration time is 100 millisecond. When it is more than 100 millisecond, that is more in favor of true severe aortic stenosis. And there have been a lot of work on the importance of acceleration time in patients with heart failure, reduced ejection fraction. Not only looking at the valve, look at the arteries, because we know that 30 to 80% of patients with calcific aortic stenosis have hypertension. So we have to look at atheromatous plaque in the aortic root. We have to do the carotid duplex, and so on. Now, looking at the valve beyond the ejection fraction, we heard elegant presentation from Dr. Ashraf this morning about the importance of strain. And this has been actually shown particularly. This is important before getting the patient into this case of severe impairment of LV function. It is easy to pick, but what's important is to pick the case before reaching such a stage. And we know that 1/3 of asymptomatic patients with aortic stenosis and normal ejection fraction have reduced longitudinal function, reduced GLS. So I think this is important to pick up before getting into advanced left heart failure. Now, this is a nice current, a novel echocardiographic assessment of the ejection fraction. Not only looking at the strain, what we have seen today, GLS here of 21 in mild aortic stenosis. This is a case of moderate aortic stenosis. And you see that it is reduced down to 16, and severe stenosis reduced down to 11%. There is actually, this is a novel model here with software incorporating the blood pressure by non-invasive way in addition to the strain information. So why? Because the myocardial deformation or getting the strain imaging, it has still an afterload, is still afterload dependent. So to overcome this, people added actually or combined the use of myocardial deformation imaging with non-invasive blood pressure monitoring, and they got what's called a myocardial work, as it is here. So this actually is important because we need in aortic stenosis to think about the mechanisms of all the changes occurring in such condition. We know that aortic stenosis lead to left ventricle pressure overload, left ventricular concentric hypertrophy, diastolic dysfunction. The LA will respond to that and cause LA remodeling. And further on, we will get left ventricle and left atrial fibrosis. And this is the cause of the heart failure and arrhythmias patients end with in aortic stenosis. We heard elegant presentation from Dr. Ala about the left atrial strain in such cases. And this is an important message here, that after SAVR or TAVR, when we assess the patients, we get actually very fruitful measurements quite early. The left ventricle volume and ejection fraction start to improve after 1 week, believe it or not. The left ventricle strain observation and improvement improve within 1 week. The left ventricle diastolic function improve, and the left atrial strain a little bit more delayed, up to 40 days before it showed its improvement. Now, one other important point is the staging of the severity of aortic stenosis. We look at aortic stenosis and we forget about the sequelae sometimes of aortic stenosis. And this actually model has been introduced in 2017 by Genero and Piparo, and they actually classified the stages of aortic stenosis into 4 stages. Stage 1, where actually you get LV damage, and there is increased LV mass, there is a reduced ejection fraction, and of course the GLS will come down. Stage 2 of aortic stenosis, when the patient starts getting left atrial and mitral valve damage, and that is shown with moderately severe mitral regurgitation, showing atrial fibrillation, and so on. And the patient progress and progress. Not only aortic stenosis is not limited to the aortic valve. It affects every single chamber and every single component in the heart. And the stage 3, where we start getting tricuspid damage, we get significant tricuspid regurgitation, pulmonary artery systolic pressure goes up, and the stage 4, when the patient gets dilatation and reduced function of the right ventricle. And this is actually quite advanced stage of aortic stenosis. Now, is this reliable staging? Yes, it has been shown recently in November 2022 in a study done on over 900 patients with TAVR. And they found that this classification was very fruitful, and there is good association between the cardiac damage and 1-year mortality. So that is a meaningful assessment. Now, what about myocardial infarction? Do patients with aortic stenosis get worse if they had a heart attack? And the answer is probably yes, because this is a study, not a large study, but it showed that in patients who had myocardial infarction, there was progression of their aortic stenosis, and that's assumed because of increased collagen production and thickening of the aortic valve. Sorry. Now, what about the stress echocardiography? Do we need stress echocardiography when we are selecting patients with TAVR? The answer is probably not, because I think the role of stress echocardiography in TAVI is less defined, while in selecting patients for transcatheter edge-to-edge or mitral valve clip, yes, there has been shown that stress echocardiography is proved to be useful. Now, finally, what is the role of cardiac catheterization in assessing patients with aortic stenosis? I think there is very limited role nowadays. It is used to clarify inconsistencies, or when there are discordance between the findings or not actually conclusive findings from the echocardiography, CT scan, and so on. But we have to remember that the figures we are getting on cath are a little bit different from the figures we are getting in gradients. So finally, ladies and gentlemen, look beyond the gradients. So look at the valve, see the calcification ratio, look at the arteries, look at the ventricle with the strain, and look at the LA strain, and do staging classification to get full picture of what's happening in the state of aortic stenosis. Finally, I will end with this statement by Carbello that in aortic stenosis, no number trumps clinical judgment. With this, I will thank you very much indeed for your attendance.
Thank you very much, Dr. Hassan. Actually, as always, you're an eminent speaker. Thank you for this excellent presentation. And as we mentioned earlier, we will leave the questions to the end of the sessions. Personally, I do have one question, so we would like to welcome our second speaker, Dr. Akram Niaz Ahmed. Please come forward. Yeah, he's over here. So Dr. Akram is actually a consultant cardiology and echocardiography at Dr. Samir Abbas Hospital from Jeddah. Dr. Akram is board certified with the Saudi Board in Internal Medicine, Saudi Board in Adult Cardiology and Echocardiography, National Board of Echocardiography from the USA. So he will here give us his talk. So welcome, Dr. Akram. Tfadal.
Assalamu alaikum. Thank you, everyone. Thanks for inviting me to this fruitful forum. Just waiting for this to connect. Okay, so assalamu alaikum everyone again. My talk today is about the aortic stenosis evaluation after TAVI or TAVR, and I'm going to start with a case. So this was a 65-year-old female who had symptomatic, very severe aortic stenosis. Her peak velocity was almost 7 meters per second, mean gradient was more than 100, and the calculated valve area was 0.4 centimeters squared. She was at high surgical risk due to comorbidities. And so based on the valve guidelines, in this patient with symptomatic severe aortic stenosis, she meets criteria for either SAVR or TAVR. Previously, the option of TAVI was mainly for patients at high or prohibitive surgical risk, but since the multiple partner trials, it's even been FDA approved in low surgical risk patients since 2019, and it's being done more and more. And now the 2020 guidelines actually recommend TAVI as a class 1 recommendation for all patients above the age of 65, okay? We know that there are two major types of prosthesis, the Edwards-Sapien valve and the Medtronic core valve. The Edwards valve, it needs to be deployed and placed by inflating a balloon after the valve has been correctly positioned. And it's got a small profile, it's cylindrical in shape. And that's what the valve looks like after it's deployed. The Medtronic valve, on the other hand, is a self-expanding valve. The mechanism for deployment, after it's deployed, you can appreciate that it's got a cylindrical or a smaller part in the LVOT, and it becomes bigger in the proximal ascending aorta. So when it comes to assessing the function of the valve after TAVR, we have to look at two major components. The first is the visual appearance, the positioning, and also to look at the hemodynamics of the valve. So in terms of position and location, we need to ensure that the valve is secure and stable in position with minimal impingement on the anterior mitral leaflet. We should also ensure that there's no coronary ostial obstruction. So this is a normal Edwards valve. The edge of the stent is usually 2 to 4 millimeters below the aortic annulus. And on the Medtronic valve, it's about 3 to 5 millimeters below the aortic annulus. When seen in the short axis, a good deployment is when the valve is circular. Sorry, the stent is, circular. But if it's ovoid, it's not fully expanded. That means that the valve has not been completely or fully deployed and placed correctly. Some common pitfalls that Dr. Hassan went over. In the native valve, we should always try to measure the LVOT diameter right at the annulus and not proximal to it. We should also try to exclude any ectopic calcification because that's going to give us a falsely small LVOT diameter and affect the measured orifice area. So in TAVR, where do we measure the LVOT diameter? It's not measured at the near the annulus. It's actually measured at the inferior edge of the TAVR stent. We take the measurement from the outer edge to the outer edge. And we should also try to position our pulse wave Doppler sample volume at the same level to get the valve area. Okay, so positioning of the LVOT pulse wave Doppler volume should also be done in such a way that we don't see any of these opening and closing clicks. We should move a little bit more proximal into the LVOT to get a complete signal without the opening and closing clicks. Also, when trying to get the tracing, We might need to decrease the gain to make sure that there's a good black-white interface that we can trace along it to get the VTI for the pulse wave for the LVOT. What about the continuous wave Doppler? The sample volume obviously should be adjusted so we don't see two envelopes. We should be seeing one dense, uniform spectral profile. And we shouldn't forget looking at the other views like the parasternal to get the actual maximum peak velocity. So the normal continuous wave Doppler signal in the prosthetic aortic valve kind of looks like the one in the native mild aortic stenosis. It's got a triangular shape, it's got an early peak, and as Dr. Hassan mentioned, the acceleration time, it's the time from the onset till the peak. So if there's any obstruction or stenosis, you're going to find that the peak is going to be farther ahead and the acceleration time is going to be increased. There's also a measure that we use sometimes, which is the ratio of the acceleration time to the whole ejection time. So if the acceleration time takes up a lot of the ejection time, that again points towards significant stenosis in such patients. Effective orifice area is obviously calculated by the continuity equation, and we all know it depends a lot on the LVOT, so any changes in the measurement or variation is going to affect the final calculated area. DVI, on the other hand, is something that doesn't really use the LVOT. It just measures the ratio of the flow at the LVOT to that of the peak velocity, and it's a simple parameter that we can calculate. Here on this table, you can find the normal values for the different kinds of valves, the Medtronic and the Edwards and the Medtronic. So even on the smallest valves, that's size 23, the effective orifice area is usually 1.1 centimeters square or bigger. Obviously, as the valve gets bigger, the area is going to be a lot bigger. So having gone through all the Doppler parameters that we need to get an idea about the hemodynamics, this is a simplified algorithm from 2009, actually. We have some updates later on. So if we have a peak velocity that's more than 3 meters per second, we look at the DVI. If the DVI is less than 0.3 and 0.25, and then we look at the acceleration time. If the acceleration time is more than 100 milliseconds, that probably suggests that this patient has significant stenosis. After TAVR, the complications can be divided into early or late. Early complications are usually like prosthesis migration or embolization. TAVR thrombosis and valve degeneration is usually late. And patient prosthesis mismatch can be both early and late, actually. This is an example of a patient where immediately post-deployment, the valve was in the proper place, as you can see. But upon follow-up, the valve actually migrated into the LVOT, releasing the native valve. So this patient had significant stenosis. This is an example of an Edwards valve that went in the opposite direction. It embolized into the descending aorta. Now coming to TAVR thrombosis, it occurs in about 3% of cases, and it should be suspected when there is more than 50% increase in the gradient from baseline, if there is increased leaflet thickness and decrease in the cusp mobility. Here is an example. This patient has thickened valves. You can appreciate that the mobility is reduced, and in this case, it was because of premature discontinuation of the dual antiplatelet therapy because the patient developed GI bleed. What about patient prosthesis mismatch? The basic idea behind PPM is that the valve leaflets are opening and functioning well. The only issue is that the size of the opening is small when compared to the body surface area of the patient. So what we find here is usually that the indexed orifice area is going to be low, and almost all of the parameters are usually within normal. If it's less than 0.85, that means there's some patient prosthesis mismatch. And if it's severe, if it's less than 0.65 centimeters square per meter square. It's obviously not benign. The worse the degree of the patient prosthesis mismatch, the worse the outcome and mortality in these patients. So in actual stenosis, the area and the index area are both going to be low. The acceleration time is going to be prolonged. Whereas in the patient prosthesis mismatch, morphology is going to be normal, Everything is normal except the index orifice area. Now let's talk about pressure recovery. Pressure recovery is when we have in the LVOT, we have something called pressure energy. And as it goes through the vena contracta, it's converted into kinetic energy. So the potential or pressure energy that we have initially is decreased. It's really low at the vena contracta. And after it crosses the vena contracta and goes into the ascending aorta, some of the pressure energy is recovered, but not all of it. Okay? So when we're measuring the gradient by echo, we're going across the whole valve. It measures the gradient between the initial and the lowest here. Whereas when we're measuring by cath, we put the cath transducer in the ascending aorta and in the LVOT, it's going to give us the difference between the initial and the recovered. That's why we'll notice a lot of times that the pressure gradient on cath is much lower than on echo. This becomes more relevant in cases where we have smaller ascending aorta. So if we have a large ascending aorta, the pressure recovery is minimal. So the difference in pressure gradient between cath and echo is not going to be that much. But in those that have a small ascending aorta, there's quite a bit of pressure recovery. So that's why we end up having a difference in pressure gradient between cath and echo. Now it's a debate which one's more accurate, which one's more physiological. But I guess by echo, we're measuring just the difference between the LVOT and the convergence, but the cath actually measures what's going through after the valve. This discrepancy was also seen in patients post-TAVR, and the difference was statistically significant as well. So the guidelines include measurements of pressure recovery. They have these formulae we can use. And they also have something called energy loss index, which takes into account this pressure recovery and gives us an idea about the corrected valve area based on the ascending aorta area, which is the AAA. We shouldn't forget that the gradient may overestimate severity if the stenosis is contaminated by the MR signal, obviously, if the traced area is larger than the actual envelope, or if we have a high flow state as well. And the gradient may be overestimated if we have, if we have failure to align the Doppler beam, if it's a low flow state, or the patient has high blood pressure. This table here is a summary of the causes of different causes for high gradient. So obstruction, we're going to have criteria that all go with stenosis. And there's also a change in the ratio of the area to the DVI when compared to baseline. There's going to be obviously abnormal cusp motion. We're going to have low DVI. And conversely, in the patients with high flow, just the gradient is going to be elevated. Everything else is going to be normal. In patient prosthesis mismatch, the gradient's high, the effective orifice area index is low, and everything else is going to be normal. Pressure recovery, we already went through the different parameters. And we're going to have no change in the cusp motion. We're not going to have a change from baseline in terms of ratio of area to DVI. Aortic stenosis is not an isolated valve issue. There's also vascular load or arterial compliance that we need to take into account. And there's also the global arterial load, or the ZVA, valvular arterial impedance. It's a simple thing we can calculate by just using the systolic blood pressure, the mean gradient, and the indexed stroke volume. So we have different values for all of these parameters to assess whether the aortic stenosis is significant or not. Going back to our case, the patient had very severe aortic stenosis, underwent TAVR using a 23 millimeter Medtronic Evolute R valve. The mean gradient after echo was around 15 millimeters of mercury. The echo as measured by, the gradient as measured by cath was around 10 millimeters of mercury. Upon outpatient follow-up, the patient was found to have a peak velocity of 4.4 meters per second. Mean gradient was 35.
You have 1 minute left.
Sure, was 35. The valve area was 0.93, but the index valve area was 0.56. The DVI was 0.41, acceleration time was 80 milliseconds. Patient had energy loss index of 0.83, which was not severe, not less than 0.65. The vascular load was also within normal. The global impedance was also not meeting criteria for severity. So looking at the reference values for the size here, the effective orifice area of 0.93 was within accepted range. The DVI was also within the accepted range, but the index area was quite low. So this patient probably had patient prosthesis mismatch, causing the high gradient. In summary, this is a simplified algorithm that we can follow to go through patients who have high gradient after TAVR, not to miss any of the diagnosis. And thank you very much.
Thank you, Dr. Akram. Interesting talk, especially, we're expecting more TAVI patients and more TAVI failure in the coming decade, so we need to have a solid indices for such patients. Thank you very much. Let me introduce our next speaker, Dr. Hani Mahmoud Al-Sayed. Dr. Hani is a consultant cardiologist and director of echocardiography lab at Aswan Heart Center, Sir Magdi Yaqub Foundation in Egypt. He's a committee member of the European Association of Cardiovascular Imaging and a committee member also of a lot of scientific and a lot of board certifications from the National Board of Echocardiography, United States, and also Dr. Hani served as a senior clinical fellow cardiovascular imaging in Queen Elizabeth Hospital, UK. Dr. Hani will talk to us about the 3D transesophageal echo in mitral paravalvular regurgitation. Please.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much for the introduction. So as it has been said, I will be speaking about the mitral paravalvular leak. What can the 3D echocardiography add? It happens usually due to dehiscence of the prosthetic valve, whether mechanical or biprosthetic, from the native mitral annulus. Although we know that it happens more frequently in the mitral position compared to the aortic and other valves, and it happens more frequently in the mechanical compared to the biprosthetic valves. Surgery has been always the treatment of choice in such patients. Previously, if we have patients with paravalvular leak, whether to leave them alone if they are high surgical risk, or to treat them surgically. But luckily, with the advancement of the interventions and the imaging modalities, I have to say imaging because I'm an imaging guy, we now, for selected patients, we can offer them percutaneous therapy. As an echocardiographer, we need to address the patient at many steps. First of all, to diagnose the patient, to detect the severity of the paravalvular leak, and to check if it is suitable to be closed percutaneously, and of course, inside the procedure in the cath lab and follow-up. We are speaking about 3D, so 3D has a lot of added values, as we will see later on in many things, especially in multiple leaks, in defining the shape and size, the localization, the guidance of the procedure, and so on. So speaking about the localization, I usually like to use the clockwise approach. Starting from the surgical view of the mitral valve that everybody saw today and yesterday, putting the aortic valve at 12 o'clock position, posterior mitral annulus at 6 o'clock position, septum will be at 3 o'clock, and the left atrial appendage will be somewhere at 9 o'clock. Having this in our mind, we need to speak to the surgeon, speak to the interventionist in the same language. So for example, even if you have a 2D TE probe, having the long axis view, which comes usually between 120 and 140, if you see a defect more or less close to the aortic valve, this is not like a sharp cut at 12 o'clock. With some tilting, we can go for like 11 or 1 o'clock, but this is more or less somewhere here. Do you agree with me? So if you see this, and you see a defect near the aortic valve, that means you can localize this somewhere near 12 o'clock position. On the other hand, a bit of angulation from the commissural view, if you see something near the left atrial appendage, we know that the left atrial appendage is around 9 o'clock. So roughly, you can say this is somewhere a lateral defect near 9 o'clock position. So what to do? This is a proposed protocol that I published 2 years ago. you have to start first with the 2D. Don't jump immediately to the 3D, and we will see why. 2D first, and then turn the color on. Why? To make sure this is not an artifact, because if it is an artifact, color will not pass through. So 2D first, and then 2D with color on. Now I can see the color is passing through. This is a real defect, not an artifact. Okay, well and good. Now we will activate the narrow sector Live 3D. Who have attended yesterday's workshop? Yeah, we have seen the narrow sector Live 3D, not the 3D zoom, not the full volume. Why is that? Because narrow sector Live 3D gives you the same frame you started with some elevation. So if you see a defect in the 2D, and then you see a defect in the 3D, this is a real defect, not an artifact. So don't let the defect go away from your sight. Stay, keep the defect in the screen, just narrow sector Live 3D, the Live 3D, then you will see the defect with some elevation, the thickness, the depth of the image. Now I know this is a defect. And then I enlarge the elevation width, which is like, falsely we can say anteroposterior, the depth of the image. We can increase the thickness. Again, I'm still seeing the defect, and then I orient the image to the surgical view. Now I didn't lose the defect. I have the aortic valve 12 o'clock position, so this defect is somewhere like 11 o'clock. Do you agree with me? So why is that? This is from down. And again, this is a straight track defect. What does it mean, straight track defect? It's like a window. If I'm staying in the left atrium and I'm looking from the defect, I can see the left ventricle, right? Because we will see other shapes of defects now with sliding track, and it has implications in the treatment. So that's a straight track defect. If you are looking like an ASD, if you are in the left atrium, you can see the left ventricle directly, whether from the LA or the LV. So this is the protocol that we published. 2D, color on, Live 3D, increase the sector width, orient the image, and then you will have the clockwise orientation. Do not get deceived by 3D immediately. If I told you this patient, that's another patient, has a paravalvular leak. Can you clockwise the defect? I think most of you will look at this, right? The same as me. But color on, the defect is there. This is just an artifact. Why is that? Because the prosthetic valve was a bit higher than the native annulus, but it is attached, it is intact, creating some shadow. So that's why you shouldn't jump immediately to the 3D. 2D first, make sure this is a real defect, then Live 3D, and so on, as we said. Color is very helpful. This is some, or more or less, a surgical view, but the defect is there at 11 o'clock. That's why sometimes I need to turn the image down to see the defect. See, the color gives very good localization, especially if you have higher frame rate. Sizing and shape. Look at this huge defect. Huge, right? So the valve, I'm not sure why the valve is not working, although all this defect is there. But I cheated you for the next time, but this is the last time I will trick you. This is the exact same patient. Okay, what did I do here? The gain. Yeah, I decreased the gain down. Many of those patients have atrial fibrillation, stasis in the left atrium. So in 3D, you will see this brown signal inside the left atrium. We tend to decrease the gain to get rid of the brown signal, right? The more you reduce the gain, the more you lose the thin tissues of the annulus and the left atrium. And you create a very large defect, which is not true. So what to do? Just decrease the blood signal, this brown signal, a little bit till you can see the valve and stop there. Don't over-reduce the gain. Otherwise, you will oversize the defect. And sizing shouldn't be done on the 3D image itself, because now with the new machines, we can freeze and we do tracing, right? We can do this, but this is not advised. In patients with paravalvular leak or mitral stenosis, sizing should be done in the MPR, like what we did yesterday in the vena contracta area. Do you remember what we did in the vena contracta? The same. We will put our lines in the middle of the defect, then we will put the third line exactly at the tips, then we'll have a short axis or an on-fast view, and we measure it. Why is that? Two reasons. We said one of them. If we measured on the 3D rendered image, it is liable for gain artifacts, like what we did. Number two is the projection. What does it mean? If you see this paper, Dr. Abdul Halim Kinsara sees this paper with a certain dimensions because he's just right in front of it. He sees the height and the width. From this side, I'm sure you will see the height the same as Dr. Abdul Halim, but the width is less because he is facing that. So if I tilted this paper, although it is the same dimensions, the projection of this paper in your eyes will change the dimensions. Now the vertical dimension have become less, right? And now the transverse dimension has become less. That's why in the 3D rendered image, you are not sure that you are really making the valve flat in front of you. But in the MPR, you don't have this problem because you are putting all the lines exactly at the tips and you don't care about the tilting because at the end of the day, you will measure on a straight image, an on-fast image. So please, image or size on the MPR. That's why some people, sometimes, those who are a little bit obese, they tend to take pictures like this, right? Because they look thinner, not like that. No offense. Okay? The same we can do with the 3D with color, like what we did in the vena contracta area, to measure the area of the defect. And we have the opportunity to grade the severity of mitral paravalvular leak using these numbers, 0.13 and 0.65 as a length, and you have with and without color. These are different shapes of defects. I'm not cheating you anymore, believe me. Here, this defect is from 6, like to 7 or 7:30, we can say. That's, again, straight defect. If we are in the left atrium, we can see the left ventricle. But look at this defect. I can see the real defect. The valve is supraannular a little bit, but there is something here, but I can't see a straight bath. It is not like an ASD. It is not, I can't see the left ventricle from the left atrium. That's why I need to get this by the Neurosector Live 3D. See that? It is bigger than the annulus, actually, and dehisced. So the defect is from like taking a sliding track from the left atrium to the left ventricle. This is very dangerous in terms of percutaneous closure. If you see this, think twice before sending the patient to the cath lab. Because the previous one, the straight one, if they inserted the catheter from the LA through transeptal puncture or from the LV, it will go straight away to the other side without touching the discs of the valve. But this one, if they try to insert a catheter from here, it will take this sliding track and touch what? The discs, and it will impair the motion. I don't care about the defect, even if I close the defect fully, but the valve is not working, so what? What's the benefit? We tried first, when at our beginning of experience, to close this defect, and we never won. Usually we get caught in the discs and then deploy or try to get away from the discs with smaller plugs, and then we have residual leak. So my advice, don't try in these kind of defects. This is a side view for the same defect, see? Up and down, this is not a straight track defect. So the guiding the closure have many steps: transeptal puncture, wire catheter positioning, and assessment of the result, and so on. Of course, this has to come through a heart team discussion. Heart team discussion is very important. The imaging guy is the wise guy in the middle. Interventionist C is looking to the imaging, asking him to say suitable for percutaneous closure. Surgery is always sad because he's losing cases, no more jobs, and anesthesia doesn't care. He's going to sedate the patient anyway. Yeah. Transeptal puncture, we have seen that a lot. The rattle maneuver to get the surgically oriented view of the interatrial septum from the right side. You can see a catheter coming from the IVC towards the SVC, and this is the fossa. You can see the catheter coming down to impinge or tent the septum. You can guide this very easily using the rattle 90 maneuver, and we have published this. If he is coming from the apex, transapical approach, you will not be able to help him seeing the catheter inside the LV, because if it is a mechanical prosthesis, everything will be hidden by the shadow of the mechanical prosthesis. But you will help him, telling him whether his catheter is coming through the valve itself or from the defect, because it can happen. Sometimes they insert the catheter, comes through the valve itself. And before they notice this in the hemodynamics and in the fluoroscopy, you can tell them, no, take it back and bring it from the defect. Wire and catheter positioning. This is through transeptal approach coming from the IVC, puncturing the septum all the way to the defect. This is another view, starting from something like a bicaval view, superior vena cava, inferior vena cava. 1 minute. Okay, I'm almost there. See? Now the discs are moving, and the cannula, or the sheath is there. This is the complication I'm telling you about, passing through the defect itself. take it back, put it in the right place. This is through transapical approach. You can see only the plug being pulled back to the catheter. Yeah, just less than half a minute. هي مع البيبل السلايد بتقف. Yeah, freeze. خلاص. So this is the final result for this particular patient. Assessment of the result, two main things. Actually, I should put this one in the beginning. So prosthetic malfunction and leaflet mobility. This is the most important thing. Safety is first. And then after that, is there any residual leak or not? 3D can help a lot. Just one view, see the defects opening and closing very well. Because 2D, you know, 2D, some cuts will give you a sense or like a false impression that one disc is not moving. But 3D, you will see both discs are moving. By color, you can assess if there is any residual leak or not. And for further reading, we published this 2 years ago, added value of three-dimensional TEE in management of paravalvular leaks. So in conclusion, TEE isn't mandatory in paravalvular leaks, but 3D has a lot of added values in terms of localization, shape and size detection, and guidance of the procedure. Thank you so much. Yes?
A beautiful presentation, as usual, by Dr. Hani. Now, our next speaker is one of our dear colleagues, Dr. Zakaria Ibn Musa. He is one of our junior colleagues in the Saudi Heart Association with a lot of activities and a lot of really promising future. Dr. Zakaria is the head of echocardiography division at Prince Sultan Cardiac Center in Riyadh. He's an adult cardiologist, echographer, and interventional as well. Dr. Zakaria, please proceed.
Thank you, Dr. Arima, and thank you for the organizing committee for bringing me back to my hometown. And also thank you for Almoosa Hospital for this nice meeting. This is my disclosure, and I will start with the history, some history though. So the edge-to-edge repair started in maybe in 1990, early 1990s, with Professor Alvieri, who's an Italian surgeon, started his surgical technique to repair the severe MR with the stitch between the anterior and posterior leaflet. It looks simple, but unfortunately it didn't do well as an outcome. So it didn't persist in the field of surgery. Then it took almost 20 years for a company to have an idea and to use it as a percutaneous intervention, and they published in 2011, In 2011, they published their data for Everest 2 trial showing visibility and safety of percutaneous edge-to-edge repair. It works, and it has it grow the popularity, and then in 2018, in co-op trial, it showed both mortality benefit and hospitalization also benefits. So nowadays we are seeing the mitral edge-to-edge repair gaining more popular. They are really increased demand all over the world and also in our country. Before to go for this technique, you have to make sure to choose the correct patient. These patients should be optimally medically treated with coronary vascularization at the beginning, and if they need resynchronization therapy, should be done first. You have to make sure that they have severe MR and they are symptomatic with recurrent hospitalization on top of all the medical treatment we mentioned. Additionally, they are having high or prohibitive surgical risk, denying them from surgical repair. The ideal case usually for mitral tear or, edge-to-edge repair, although these are rarely we are seeing, but I would say they should have the single jet between A2 and P2, no commissural jet, thin mobile leaflets, no leaflet calcification, no MAC, not rheumatic, with posterior mitral valve length of more than 10 millimeter, the mitral valve area more than 4, gradient is low or no gradient, make sure that there is no very large gap for primary MR, no severe LV dilatation with adequate septal height. The proposed protocol for screening of these patients to choose these good, to have an ideal, or let's say for your selection for the procedure, it includes both transthoracic echo and transesophageal echo, including you have to assess, the mechanism of the MR, the severity, the LV assessment, and the look for any prohibitive condition, which we mentioned later on. The transesophageal is the golden, let's say, investigation or the imaging technique for those patients where you have detailed assessment of the mechanism of the MR, the mitral valve apparatus, look for unfavorable features, you assess the interarterial septum and the LA appendage, and then you have to make sure, you have to decide about your choice of the device, which device you're gonna choose. So starting with the mechanism from the transthoracic echo, you can easily look for, let's see. Yeah, so you can easily identify the primary MR where you see any prolapse or a flail leaflet, or look for the secondary features where there is a tethered posterior mitral leaflet with a relative prolapse of the anterior mitral leaflet associated with LV dysfunction or regionality in the posterior inferior wall. Look, exercise your knowledge and the whole guideline, let's say, that you know for assessment of the MR severity, including the mitral valve morphology, qualitative measures or qualitative assessment of the mitral valve regurgitation, and then the quantitative assessment, including the vena contracta, the BISA, and also other parameters. So you have to make sure that you are dealing with severe mitral regurgitation. For LV assessment, you go for the dimension. Make sure that you have a good assessment of the dimension, although I like to go for the volume, because simply the volume will give you an idea what you are dealing with. So we know that we said about COAPT trial, which showed a positive result, but there is another trial, which is the MITRA France, it showed a negative result. So the only explanation for that the selection of the patient for the MITRA France, the LV dilatation was, the MR was proportionate for the LV dilatation. And those patients, if you do for them the edge-to-edge repair, they have less benefit. Well, on the other hand, the COAPT and the EFEREST were selected earlier in their journey of the disease, where they have disproportionate MR. What does that mean? It means that the degree of the MR is disproportionate to the degree of LV dilatation, and those patients, they benefit the most from the procedure. So you have to maybe catch your patient early in the disease, not to leave them till they lose the benefit of the procedure. Now, going to the transesophageal echo, so it has the major rule to identify the mechanism accurately, whether it is a primary or secondary. Again, assessment of where is the MR segment, the mitral valve segment that involved in the etiology of the MR. So you decide where is it to decide your strategy for the intervention. Like here, it's a primary where it is more of a lateral flail segment of A2 toward A1 maybe. On the other hand, when it is a secondary, you will see that the posterior leaflet is restricted and there is a relative prolapse of A2, segment of the mitral valve. Importantly, also to look for if there is any gap, and the location of the MR as well, whether it is, as I said, middle, medial, or lateral. In the primary mitral valve disease, you look for a flail gap, and you measure it, and the flail width, which should be done in the bicommissural view. The assessment of the posterior mitral valve leaflet length should be done in the 120 or 130 degree, where you have to measure the mobile part of the posterior leaflet, and to avoid the chordae, not to measure it, so it will give you a longer measurement. Importantly, to assess how many segment, as we said, how many jet of MR, whether it is a single MR, jet of MR, where is it? Is it located centrally or medially? Because this will affect the choice of the device and the number of your strategy for the number of devices you're gonna use during the procedure. As we said, and we also, you might go, you have to assess how wide is the jet, whether it is narrow or wide, because this will affect your strategy for choosing of the device, as we said. 3D has important role to identify the location, and as well how wide is the jet as well. Important part of your assessment to go for the pulmonary vein flow reversal, which is observed during the procedure, before and after, because this is a hemodynamic result of your procedure, whether there is an improvement in the pulmonary flow before and after the procedure. Sometimes I use the LVOT VTI to look for the stroke volume before and after. However, there is a bit of controversial, because we know that the stroke volume and the LVOT VTI is not only affected by the mitral valve regurgitation, it's affected by the LV dysfunction and the ejection fraction. So sometimes we do use it, but we are carefully interpreting that during our procedure. The mitral valve apparatus is an important part of your assessment, because you want to know the distribution of the chordae, how is deep, and if there is any calcification in the chordae. Simply because when you have a jet that it's in between these chordaes, you want to make sure that you avoid entrapment of the device during your procedure. Part of your assessment as well is to assess the mitral valve area, which I agree with Dr. Hani for the assessment. I don't usually assess the mitral valve area on the 3D, but directly. You have to use the MPR for assessment. This is very accurate assessment of the mitral valve area, and look for the gradient, which should be less than 5. Optimally, it should be less than 1 or 2. The intra-arterial septum is part of your assessment. You have to look for the thin septum. Try to avoid the PFO during the transseptal puncture, and you look for the thin and any interfering with the devices or the ICD as well. The intra-arterial septum height, it should be done in the 0 degree, and you should take it from the coaptation line or from the annulus to the thin part of the septum. Make sure that you get more than 4.5. We do sometimes less than 4, but it will be difficult for the interventionist, so they have to know to do some maneuvers to gain height during the procedure. Now, unfavorable features for that you might not go for mitral valve clipping or edge-to-edge repair is the mitral valve annular calcification, significant, severe calcification that protrude into the LV cavity. Rheumatic mitral valve you should avoid, because simply you can see there is a fusion of one of the commissures, and the area will be low and the gradient will be high, so these are not suitable for mitral valve clipping. assessment of the mitral valve area, as we said, it's important. And finally, the short posterior mitral valve leaflet, less than 6-7 millimeter, is really difficult for, especially for early experience. The lowest we have done is 7, and really it was difficult to grasp during the procedure. Just one more slide. So the choice of the device, so it depends on the posterior mitral valve leaflet length. For smaller, shorter posterior mitral valve leaflet, we use the NT, whether NT or NTW. For larger one, or more longer posterior mitral valve leaflet, we go for XT. Now we have 4 devices: NT, NTW, XT, and XTW. For the W, it is wider, so this is should be selected for wider jet. The other device we are having is Pascal device. It's a larger device. It has a spacer within. It's claimed to be nicer and more delicate on the leaflet. It has also good result. There are 2 sizes of the Pascal, B10 and B6, and still we are having the early experience with that device. So in summary, the echo protocol for mitral valve tear screening, it should include transthoracic echo and transesophageal echo with full details of the mitral valve anatomy, mitral valve regurgitation assessment, full assessment, and suitability for the device. Look for the prohibitive conditions and the interarterial septum, and the choice of the device you should decide it after full assessment. Thank you.
Thanks, Dr. Zakaria, for this excellent presentation. We are coming across the end of this session, so I would like to call the speakers forward. We will have like 5 minutes to get some questions. Less than 5 minutes, okay. So I have actually 2 questions if somebody doesn't have, So I have 2 questions. A question to Dr. Hassan about aortic stenosis. You mentioned about the longitudinal strain affection, which is an early stage in the aortic stenosis. Would there be like a cutoff value where you can predict or send patients earlier before they drop the ejection fraction? Because still, till now, the guidelines are all talking about ejection fraction as a number. And I have a second question to Dr. Hani about 3D echo and optimization of the 3D. So do you have like a specific range for optimization when you have a 3D zoom to eliminate all the dropouts and the artifacts you see in terms of the gain, compression, smoothing, and also thickness? If you have like numbers or ranges, you can give us also will be nice. So Dr. Hassan.
Thank you very much indeed. Excellent question. Answer in the guidelines, it is not. There is no to give actual for surgery. But I think, having said that, I think some people, some authorities say 16% is probably an indicative of early procedure or early intervention. In the guidelines, still actually it's not well defined.
شكرا دكتور. Very practical question. Actually, there is no single number that can work for every single patient. As I said, some patients have a lot of stages, atrial fibrillation, very large left atrium, and some of those you will have to decrease the gain compared to other patients. But as like a simple answer, start by an average 2D image. So play all of your like tricks on the 2D image first, and then it should be fine. For this particular patient, if you see a lot of stasis, the patient left atrium above the valve before on the 2D, decrease again till you get an average image on the 2D, and then start acquiring the 3D. For the sizing, Yeah, that's an important point. I usually, when I do a patient, I take 2 sets of images. Some images to show the interventionist or the surgeon. This is, I have to reduce again to show them the valve, okay? But on average, reduction to avoid artifacts. And some other images overgained. Even you can't see anything in them. And when I display this in front of them, I tell them this is only for sizing, ignore it. So I put the overgained images in the MPR, okay? So I take 2 sets of images, one to show people, and the other ones are to do the offline analysis using the MPR, because if you overgain an image, still in the MPR, you will see a difference, a contrast between the blood pool and the tissue, and you will completely avoid any dropout artifact. Is that clear? So the images on which you will do the offline analysis, overgain them, okay? Acquire them overgained, even if you can't see anything in them, just like brown lump. Because in the MPR, you will still be able to see the difference between the blood and the tissue. And that, by this, you avoid any artifacts. But you have to take some images to show the surgeon or to show the interventionist that in that images, you should reduce again a little bit to show the structure. I hope that answered the question.
Thank you, Dr. Can we take one more question?
I have, okay, please, yes.
Any question?
We have plenty of questions now.
Thank you. Excellent presentation, all of you. One question for paravalvular leak in the setting of infective endocarditis. I have a young female. She had mitral valve replacement for rheumatic baseline. And after 5 years from the surgery, she came with severe paravalvular leak. Closed percutaneously by Dr. Rida. After 5 years, she came with pseudoaneurysm, large pseudoaneurysm. Most likely the underlying pathology is endocarditis. Dr. Hani. My questions, paravalvular leak in the setting of endocarditis. What is the best treatment? Another question for Dr. Hassan. One question allowed?
That's a more of a clinical question rather than, but I think this is a common clinical scenario. That's why we shouldn't intervene with any patient during an active infection, unless we do surgery. I mean, percutaneous approach in patients that is just recovered from infection or on active infection is contraindicated because you don't know how far the things will go. This thing was actually, it might be an extension of the pre-existing infection, and this is the normal process, thinning out and then pseudoaneurysm. You successfully closed the defect, but things were like getting worse and thinning out, and with the hemodynamics pressure overload, these thin parts became an aneurysm. That's why we shouldn't intervene with patients unless they are very well settled, very well established, get them out of infection. If they are not in active heart failure, give them some medications, like let them settle. Everything will be fibrosed, and then operate on them, whether percutaneously or surgically. Yeah.
The golden rule that, I'm a pediatrician basically, but the golden rule is that we've learned and we're still learning, don't send patients with active endocarditis to OR. And a good surgeon will not accept those cases. So this is one of the sequelae that something was done without complete treatment of the pathology. Maybe it was something in the tissue, an abscess, whatever is there, we don't know. 6 weeks, okay. And all her parameters were negative, ESR, CRP, whatever, okay.
But so that when the reason of the paravalvular leak or the problem is the endocarditis, it tends to reoccur. And unfortunately, there is maybe hidden organism that will flare up later on, even with adequate antibiotic. So it is a dilemma how to treat this patient, because most of them, even if after surgery, they will develop another paravalvular leak. So I don't think we have an optimal plan for these patients.
Just one quick comment. Look for other hidden causes of endocarditis. Q fever, brucellosis. I've seen several cases. The cultures, all cultures are negative, and yet the patient has got a brucella endocarditis. So I think you have also to look for other causes of hidden endocarditis. Thank you.
This is an important teaching point from Dr. Basha. This is important for all of us. Where do you get the best gradient for aortic stenosis? In the parasternal long axis? Because, I mean, this will all the suprasternal where you can get. And another thing to Dr. Akram, because you were saying that avoid the two peaks, while Dr. saying with the two peaks you get a different index in the aortic valve.
Thank you very much. I think the conventional method, usually we look from the apex, but it has been shown that taking the picture and the gradient from the right parasternal, upper parasternal, is very, very fruitful, and you get the highest figure of the gradient.
So not the long parasternal, the right parasternal.
Right parasternal, right upper parasternal.
Thank you, Dr. For the two envelopes, for the DVI, you could use it, but if you want the mean gradient or the peak velocity, it's always best to take the densest signal without having two envelopes in it.
Also, we talk about mean aortic stenosis. That will go and correlate with the CAT numbers, right?
Most of the time,
As cardiologists, please correct me, we don't go by peak percent and for balloon or for surgery. We always get the mean.
both peak, mean, and
Decide whether to send for cath or surgery. I have a baby who's about, she's about 10 months.
Right.
Congenital aortic stenosis, and her gradient is 60, her mean is 30. So I will not defer her for balloon until we get a
Sure. Totally agree.
For the gradient point, as much as the precursor aligns with the flow, we get the highest reading.
Yes.
We have to conclude just we'll honor Dr. Rima back.
I would like just to apologize for the delay of this afternoon session. The first speaker for this session is very well known in the field of echocardiography. He was the president of TomTech, and everyone in echocardiography knows what TomTech means. Dr. Bernard Mumm, he is going actually to join us now, and he's going to talk about artificial intelligence in echocardiography. He is a pioneer in digital technology and in different models of echocardiography. He is really a great genius man. He is going to tell us his experience in artificial intelligence in cardiology. Thank you. Dr. Bernard.
Dear Chairman, thank you very much for a very kind introduction. Just to check, you can see my presentation. Can you hear me?
Yes, doctor, we can hear you.
Yes, we can hear you.
Okay, very good. So, ladies and gentlemen, it's my great pleasure to give this lecture about artificial intelligence in cardiology at the Almoosa Echo Conference, and I would like to thank the organizers for giving me the honor to invite me. I've been in Saudi Arabia a couple of times in the past before the pandemic in Riyadh and Jeddah, so this time only, unfortunately, in the virtual format, but anyhow. So my disclosure is I'm a research consultant for TomTech Imaging Systems here now in Munich, Germany. So if we talk about artificial intelligence, I think it's anyway already around us in our daily life in cars. So we already have cars driving automatically, following the car in front of us, holding the line and so on. And pretty soon we will have completely autonomous cars driving around. Google search is full of artificial intelligence. Our smartphone is full of artificial intelligence. So it's nothing new. It's around us, even if we do not recognize that in our daily life. But how is it in medicine? And I think there is no day without news about artificial intelligence in medicine, everyday new publications, new facts, how good AI is working in medicine, and that AI is always better than human beings. So in our area, AI in cardiology. And I use now artificial intelligence to ask this question. So there is a new chatbot called ChatGPT by a non-profit organization called OpenAI. And this tool is really amazing. So I entered this question into the tool. I entered the question, give me an overview about AI in cardiology. And within 1 second, it gave me this answer. AI is being increasingly used in cardiology to assist the diagnosis and management of cardiovascular diseases. And then within the next second, it gave me even all the details, like AI will be used in image analysis for automatically analysis of echo, CT, MRIs, and so on, or to come up with predictive event, like a heart stroke, heart attack, or so on, or that it can help in personalized treatment in order to identify the best treatment for a specific individual patient, but probably most important, to do a data analysis on so-called big data, which is not possible anymore by human beings, to automatically analyze a large amount of data to find patterns and identify probably patients for a specific treatment. So, and this summary as well is given to me by OpenAI, that AI in cardiology has the potential to improve the accuracy and efficiency of diagnosis and treatment. And I must say this is a little bit frustrating, because I know that that all these points are true, because I had basically nearly the same points in my previous lectures as a slide, but it took me a couple of days to put that together, and this AI bot gave it to me within probably 3 seconds. So what's about cardiac imaging, and that AI is so important as well in our area, showed that the European Association of Cardiovascular Imaging, they made a special session about artificial intelligence, an online session at last year's December meeting the online meeting, and they showed then how AI can revolutionize cardiac MRI or cardiac CT with all new algorithms here, or even nuclear medicine. But for sake of time, we will look for use of AI in echocardiography. And this was nicely summarized by this article published in Chase last year, telling us the future guidelines for AI in echo. And this group of authors came up with this 4-5 points here, that AI will change the world in image acquisition by helping us, or the cardiologist, the sonographer, to come up with better image quality during the acquisition, then an automatic interpretation of the data with an automatic measurement like auto-EF, auto-strain, or all the cardiac measurements will be done automatically. And this is already reality, and I show you some examples a little later, and so on, diagnosis and prognosis automatically provided by the AI algorithms. There was a very nice lecture, the famous Feigenbaum lecture at 2 years ago, American Society of Echo Conference, and Dr. Cuddy, he summarized that very nicely, and he called it analytic intelligence. So what does that mean? So in analytic intelligence, we do not look at one specific question like what is the data we get from imaging, echo, MRI, CT, and so on. What is the data we get from the pathology lab or the blood tests and the lab diagnostics? And all these data are now put together in this analytic intelligence cluster-based algorithm, and then the algorithm can look at all the data at the same time. And an example for this patient here, giving us then the probability of a risk that this patient needs to take ACE inhibitors or something like that. So very powerful tool in the future. Another nice publication here by European Heart Journal, showing us the pathway to the future of cardiovascular medicine. And what they said is that what are the 4 major aims overall in medicine? To predict and diagnose a disease, understand the history of the disease, and then optimize the prevention and management. And all these 4 aims, AI will increasingly be valuable in every day's work for the physicians in the future. And why do we really need new tools? If we look to the problem of medical data, so right now, a lot of the data, over 75%, are unstructured of all the patients. And you get a lot of data for every patient, more and more every year, image data. Think about the high-resolution CT scanners, how many images you get per scan, and you are not able to look at all the images anymore one by one, or the measurements, biomarkers, lab data, risk factors, trending, and so on. So there will be, or is already, an overflow of data, and there is less and less time really to treat the patient actually, or to look at the patient, because you're working with the computer. And I believe that AI will be the solution here to automatically extract the information from the data, do automized measurements, and not by hand anymore, means much more reliable, much more reproducible, and even very important, create clinical findings completely independent from the physician's experience. So an example, if we look to an experienced hospital like the Almoosa hospital here, all compared to a very small rural hospital, the algorithm will always do the same result independently of the local physician's experience, which is a very beneficial situation. So let me share our vision of an automatic analysis in echocardiography, and a lot of these things are already working and implemented. It's not future. So the acquisition is done on the ultrasound system by hand, and but assisted by AI. And as soon as all the data are acquired, they're automatically stored to your hospital cloud storage, or even to the real cloud storage. And then as soon as they are there, an AI algorithm, an AI server looks at the data, is analyzing all the data, is doing all the automatic measurements on the data according to the predefined wherever you are in the hospital, you can look at, already have such devices very seconds after the acquisition. So if we look to the echo workflow here, image acquisition, as said before, even here we develop tools which are doing an auto detection of views, like automatically telling us this is a 4-chamber, this is a 2-chamber, 3-chamber view. And here's an example of such a tool called Echo GPS. And here you see a position sensor on the probe and a smartphone. And as soon as the algorithm, the AI, is identifying a good or perfect, in example, parasternal long axis view or short axis view, the view is locked, and then the guideline tells you go now to the next view and so on. So this will help really to acquire much better quality data, which are then used for an automatic analysis. So the measurements are done completely automatic, and this is already reality today. And we published that as a TomTec group together with the World Alliance of Societies of Echocardiography already last year, 2 years ago. And here, with this algorithm, we could automatically recognize all into a convolutional neural network AI algorithm, and then all the related measurements only been published here to all the publications about AI in many areas in medicine. Always this is a typical accuracy, over 90%. And then the automatic measurements could be done at least with a similar accuracy like experts, because we do not have anything else to compare it with than experts. So very promising, and this is already reality. What do we mean if we talk about artificial intelligence? This is just a term more or less to tell us and it enables rooms for the computer to learn from the data itself. And another subset of deep learning, machine learning, is deep learning. And here learn from data in an unsupervised or supervised way. And this is probably the most dedicated algorithm for medical data. Most of our algorithms are deep learning algorithms. We give just an unstructured data, like this group of people, into the algorithm, and the algorithm by itself is then finding clusters like the green cluster, the blue cluster, the red cluster, and so on. Or here on the right side, so-called supervised learning, where we tell the, and then the algorithm is creating by itself a model predictor and can do it then automatically. So in our area, we do the same. We tell the algorithm, these are 1,000 examples of a 2-chamber, of a 4-chamber, of a 3-chamber view. And by that, the algorithm learns and can do then this detection automatically.
Dr. Bell, now
Sure.
3 minutes, please.
Okay, yes.
Thank you so much.
There are limitations, and at the American Society of Echo last year, Dr. Pendin, he showed this. So, and he proposed then the term real intelligence as the combination of AI and human intelligence. So to come to the end, let me show you an example. As I know, Saudi Arabia is football, soccer addicted, how AI can make mistakes. So this AI algorithm was controlling the camera of a football game, and the algorithm was trained on this ball. But then, unluckily, the line referee had as well a bald head, no hairs, so it looked like the ball. And let me show you what happened then. During the entire game, the automatically AI-controlled camera was always moving away from the ball, always back to the head of the referee. And so people always missed watching this TV, the soccer game, the goals, because the camera always was going back to the ball. And this shows if the algorithm is not trained well, mistakes will happen. And just assume this would happen during the upcoming game here from Cristiano Ronaldo and Messi very soon, I think in Riyadh. And you would be upset not seeing the nice goal from Ronaldo. So this brings me to my end and my take-home message. I'm very confident that AI will help to make the diagnosis faster, more precise, more reliable, more reproducible, and help the physician to put more time on the patient and hopefully have more empathy shown to the patient and have more time for really complex cases. So therefore, it will help physicians to improve patient care. So with that, I would like to thank you very much for your attention.
Thank you very much indeed for this excellent lecture. Unfortunately, because we are lagging behind on the schedule, I think there will be no questions. So thank you so much, Dr. Bernard. Thank you, very kind. We can move now.
Okay, so we will move to the next speaker, Dr. Fatima Gaddoura, who is a non-senior consultant non-invasive cardiologist. Dr. talk about assessment of multi-functioning mitral valve, bioprothesis, and transcatheter mitral valve in valve.
Assalamu alaikum. Thank you for the organizing committee. Thank you for Dr. Ala and chairpersons. Unfortunately, I'm supposed to talk for around 20 minutes because I have two topics, but I was told by the organizers, yes, that I have to go a little bit lower. So I'll try to skip as much as I can from things that, so allow me please if I go fast and I skip things. So I will talk first about the mitral valve apparatus, and just to know for the people, juniors, that it's combined from the annulus, leafless, chordae, papillary muscles, and left ventricle. This is the views that we see it with the 3D, where we're seeing the anterior mitral leaflets and the posterior mitral leaflets with the multiple scallops present there. What were the indications for the mitral valve replacement by prosthesis or mechanical isovalvular stenosis, regurg, or endocarditis? And as you could know, you know all that the incidence of having mitral valve prosthesis, bioprosthesis, usually it's common between 20 to 40 and above 60 years of age, while in the middle it's more of a mechanical prosthesis. Those are the types of the prosthetic valves, the bioprosthesis, stentless, and the stented valves. And they have, this is the normally functioning valves with the normal aliasing of the prosthesis without having any obstructions and freely mobile leaflets. And there is an intravalvular mitral regurg, which is usually of normal variant. This is the type of valves that we see in systolic and diastolic from the atrial side and ventricular side. And this is, you could see that there are 3 scallops from the atrial and from the ventricular sides, where you can have the stents also protruding and the annulus. The way to assess the hemodynamic status of those valves is to do the LVOT measurements and be always careful to take it from the inner edge to the inner edge. And if there is any calcification, skip that calcification and go back to the mitral annular area and check the LVOT VTI, which is very essential in those patients to make sure to take it not over or under signal dose, because it will be an artifact and will not be appropriate. And the second thing you have to take in those patients with the mitral valve prosthesis, a continuous mitral valve Doppler to have the TVI. According to this, you will go and calculate the LVOT stroke volume from the area and the VTI. And with this, you can get the mitral valve area by dividing the LVOT stroke volume over the mitral VTI. One of the things that we have to monitor in those patients with bioprosthesis, and very essential, is to have the Doppler veracity index and divide the mitral VTI over the LVOT VTI. In opposite to the cases of the aorta, where you divide the LVOT VTI over the aortic valve. So you have to be careful in this one. This is another way of assessing the mitral valve prosthesis by PISA and by the vena contracta. Those are the parameters which we will go after later on over it. This is the modalities that we screen the patients with. It's usually the transthoracic and TEE to evaluate for any patients having any valvular dysfunction. However, the CT and the PET scan is a very important and essential, especially in the cases of endocarditis. It has been shown that the PET scan is a valuable one where it can predict the cases of progressive degeneration of the prosthesis, even when you have a normal echo and CT. So it is essential in certain cases. Patients present usually with the acute heart failure from regurgitation or obstruction. They can have embolization from thrombosis or endocarditis, and they can present either early with a structural failure of the valve, paravalvular leak, early infection, or prostatic mismatch. Venous formation can occur also at the later stages with thrombosis and dehiscence. This is very nice article, has been elaborated to tell you exactly the steps that you go by in order to evaluate the patients for valvular dysfunction, the bioprostatic valve dysfunction. And they have divided them on non-structural and structural, and this will go on in the coming few slides. This algorithm, it looks busy, but it is very nice stages that have been elaborated to tell you first that you have to assess the hemodynamic status, the etiology, and then the follow-up of those patients of bioprosthesis in order to reach a conclusion of failure or dysfunction of the valve. So when we are assessing the hemodynamic status, the first one is the DVI, which is the Doppler velocity index, if it is more than 2.2, if the effective orifice area less than 2, and if the mean gradient more than 5 with minimal MR. The second stage is to know the etiology. As you know, there are multiple causes for it: wear and tear, calcifications, pannus formation, endocarditis, and thrombosis. And with this, they have divided the non-structural nicely in cases it is underdiagnosed. And they have placed numbers where it is severe in patients below. Moderate prostatic mismatch, it is one of the 10%. And the presence of severe mitral prosthesis mismatch, it does affect the outcome and not causing a regression of the pulmonary hypertension. We'll get the next one. The same angle. While I'm still in the zero, you may be fooled with it and not seeing it. And you could see here it's a tilting of by Dr. Hani at 1 o'clock. You could see nicely the defect. Tear of the valve, leaflet disruption, flail leaflets, leaflet fibrosis, or stress fracture. And this one, you could see it very nicely. I need your comment in one thing here. You could see here the leaflet. Okay. There is a flail also leaflet medially, and there is a significant MR showing, right? What's the difference between both? Anyone can tell? Additional? No, this one. From where the MR is coming? This one. Is it coming from the valve itself, from intravalvular where the connection is the communication? Or is it coming from... Can't you see it is coming from the base of the mitral? It's not coming from the coaptation. It's not coming, okay? Right, so it's not, so this is one of the things I was really staying with this echo just to see from where it is coming. And when we see it here with the mitral, despite the echo drop signs, you could see that there is some source of dehiscence of the valve itself, like a torn area. Oh. Here. So you could see that there is an MR coming from there, and when we did surgery for this patient, it's a torn cusp tear totally from the base, okay? And this is very rare presentations of those patients. The next one is just a mitral valve which is not working. This patient was critically ill and showing obstruction and significant mitral regurg, intravalvular. And this is an obstructive type where you could see that there is one of the two leaflets are not moving and only one leaflet is moving and causing an obstructive early degeneration of the valve. The next step is thrombosis and endocarditis. And it's a bit difficult sometimes to differentiate between both. And this is the rule here where you can have the PET scan in it, because it can show an uptake increase more with the cases of endocarditis to differentiate between both. However, the bioprosthetic valve thrombosis is something also which is also common and need to be looked at, because those patients, they can develop thrombosis, especially in patients with atrial fibrillation, previous thromboembolic events, and hypercoagulable condition. And the predictors has been shown that if he has an mean gradient which is increasing more than 50% with subtherapeutic INR. This is just to show you how difficult it is to tell. This is a mass on the mitral valve prosthesis. After 1 year, patient stopped till anticoagulation, and we don't know whether it is endocarditis or thrombosis. And patient cleared after taking antibiotics and antithrombotic agents. This is a mass which is extending from the mitral, from the LA, all over down to the prostatic valve, causing restriction of the posterior mitral leaflets. Stage 3 is the follow-up. Follow-up of those patients is to see the structural deformation of those patients, whether it is paravalvular or non-valvular, and if there is any progressive deterioration in their DVI, more than 20% or more than 25% in their mitral valve area reduction, or increasing in the MR with the increase in the gradient more than 10. The stage that we reach at the end is to document that this patient is having a bioprostatic failure, not only dysfunction. It depends on the criteria 1, 2, 3. The first one is just any bioprostatic with a new onset of symptoms, whether we have LV and RV dysfunction with significant pulmonary hypertension. And irreversible stage 3, and criteria for 3 is the one when you have failure and death of the patient. Conclusion for these patients that post-surgical and transcatheter mitral valve prosthesis has limited durability. However, the definition of structural dysfunction requires confirmation of imaging, permanent changes in the structure of the leaflets, and in the hemodynamic effect. And do not consider only the death of the patient is because of the failure, because there are lots of cases for failure even when you are causing intervention. How many do I have left? 3 minutes. I'll go quickly on the 3 minutes مع 10 and 15 هدول من غير 4 زيادة. طيب.
4 minutes عشانك.
Okay. So this is a transcutaneous in comparison with the surgical. This is very important because during the last decade it is progressing very quickly, and transcutaneous is increasing. And when they compare the transthoracic, transcutaneous to the surgical procedure, they have more high STCS score, less total procedure time, less coronary bypass time, less shorter ICU and length of stay. They have less new AF. They have less major bleeding and ventilation. So in general, they have a better outcome than the other one. And of course, you go for it because you are trying to avoid reoperation and excavating of the mitral valve and shorter stay in the hospital, except as we discussed today, patients with a prostatic endocarditis or LVOT obstruction or combination with CABG and other valves. Those are the valves that we are talking about. One few things about the choosing of the size of the valve. Very important to know that the label size is not the size that we are using for the valve in valve, and it's the true one is the one which is CT guided or by the TEE. And of course we have caveat for this in order when we are doing it, in order to measure the inner area for the mitral valve bioprosthesis to determine the size. And you have caveat with the CT and with the TEE, but you have to combine both together. The oversizing is very important. You have to make sure you're not causing stenosis, you're not causing regurg, and at the same time, not to make sure that you're not causing any embolization or migration, because the closure pressure over the mitral valve leaflet is much higher than the aortic, so it can cause it much more. This is very nice slide just to tell you exactly what to do in those patients. When you are deploying the valve, very important to make it 80 to 20, a ratio between LV and LA in most of the cases. And if you migrate a little bit or propagate into the LV, you cause LVOT obstruction. The flaring of the mitral valve bioprosthesis, the initial one, can cause this also LV obstruction. If the angle which we are measuring in the TEE less than 115, this increases the risk of having LVOT obstruction. Septal thickening more than 15 also can cause this. And a very important one, the predicted new LVOT area, which is measured by the CT when you are placing the mitral valve in valve, is not to be less than 2 centimeter. The area also which is important for us to look at, just a minute please. Height of the where the procedure, our rule in those patients is to make sure that the height where we are doing the transseptal perforation is to be around 2.5 to 4 centimeters in general. There are two papers, one of them I'll show you, transapical and transseptal. The transseptal has a much more popularity with less side effects, less perfusion conversion to surgery, and all-cause mortality is much better with the transseptal over the transapical. And the 5-year, this is very important one to show you just how it is for 5 years outcome of those patients. They have noticed that the transcutaneous is much better per mortality in the first year only. And then it flip over and cross over in that one and become, at the end, the surgical cases have better outcome than the transcutaneous. They have elaborated in this that most probably because the baseline for the transcutaneous patients having elderly ages with more chronic disease and significant pulmonary hypertension. However, the hemodynamics of those patients were almost the same between transcutaneous and surgical. Transcatheter mitral valve and valve preferable to reduce surgery should be the standard of care. Patients who have failed surgical prosthesis and who have favorable anatomy, you have to have a good planning, and it's critical to evaluate the valve size and LVOT obstruction risk. Thank you.
Thank you very much. It was very excellent talk. And now we have a very interesting talk from Dr. Mustafa Al-Rifai. He's a consultant cardiologist in Saudi Al-Batain Cardiac Center, and he will enlighten us with an interesting case of TE cases. Please, Dr. Mustafa. Your time.
خليني اشغلك شوي. خلي بعد التايم.
نغير فيها
لانه والله
ارجع بلاي افتح بعدين نروح الكلينيكال كليرة. طيب السلام عليكم ورحمة الله وبركاته. Thank you, Dr. Ala. Thank you for the organizing committee for giving me the chance to present in this prestigious meeting. I will be fast and to the point. So this patient, he's a 57 years old male patient. He's a known case of long-standing hypertension, diabetes. He presented to our center, Al-Batain Cardiac Center in Dammam, with prolonged chest pain. He was playing card with his friend. Suddenly he got chest pain, severe chest pain. So he came to our emergency medicine. So he had ECG, which shows significant ST depression in lead V4, V6, and his troponin was elevated. So he was given nitroglycerin, IV nitroglycerin. So his blood pressure dropped from 150 systolic to 80/50, and he has pulmonary edema. So he had chest pain, ischemic chest pain, ECG changes, elevated troponin, hypotension, pulmonary edema. And clinically, he has band systolic murmur. He had systolic murmur at the base, and another apical systolic murmur grade 3/6. So with this clinical scenario, and almost cardiogenic shock, and he's very sensitive to nitroglycerin. So what will be the next step to do? Next. So where to go? To admit him to CCU, or to take him to the cath lab, or to keep him in emergency room with some supportive measure? Stabilize with what? With inotrope. So we give him inotrope. So we need to raise the blood pressure. So his blood pressure 80/50. He came with a blood pressure 150 with a small dose of nitroglycerin. His blood pressure dropped to 80, 70, 60 systolic blood pressure. So we give him inotrope. Vasopressor. So he get worse. Cardioversion. Why? No arrhythmia. So you want echo. Okay, we will show you the echo. So this is his echo. He has good systolic function, right? Dilated left atrium, maybe because he is long standard hypertension. He has LVH, hyperdynamic basal part of the septum, good RV function. Okay? So there is turbulence. Okay, so the money is here. So SAM. So significant SAM, and this explains his systolic murmur at the base of the heart. So significant SAM with, okay, now you can see two turbulence, one in the LVOT, one in the mitral valve. So he has significant LVOT obstruction and significant mitral regurg. The mitral inflow looks okay, again, same. Okay, so this is the gradient. We got significant gradient with dagger shape sign in the LVOT. Okay, so gradient, we got mean of 105. So what will be the next step? We give him fluid, we give him normal saline. So the treatment, he's in pulmonary edema. So not diuretics, not inotrope. So the treatment is fluid, normal saline, plus beta blocker. Yes. So then what we should do next? So we take him to the cath lab. So? So this is his coronary angiogram. So he has tight lesion in the LAD and very tight lesion in the LAD and also tight lesion in the circumflex. So now for our heart team discussion, what to do? We have a patient with acute coronary syndrome, maybe an anastomy, significant mitral regurg, significant LVOT obstruction. So he go for surgery, for mitral valve replacement and CABG. This is part of the heart team. They are advocating this, or to go for BCI to the LAD and to the CIRC. So who will be with the BCI? So we did BCI to the LAD and to the CIRC. So now we are interested to see the echo after BCI. So you see the turbulence in the LVOT disappear. Now maybe there is some mild SAM, mild MR or no MR. After now you see here the abnormal relaxation, before maybe pseudo-normal, And you see the gradient now came to 13/8. So the LVOT obstruction disappeared, the MR disappeared, and patient did well without the knife of the surgeon.
Three minutes يا دكتور.
3 minutes? Oh. طيب, where is the IT? Can I change the... So I need somebody from the IT? Okay, so I'll give you... I have another 10 cases. Next presentation, the other presentation, quickly. Interesting TEE. Close. Interesting TEE cases. Mustafa, Dr. Mustafa, yeah? Open Dr. Mustafa. Close maybe this, or you go.
Representation of acute?
Not this one. There is interesting TEE cases.
Where exactly is it?
You should put it under Dr. Mustafa.
It's already, this is the folder.
Only one? No. Interesting TEE cases. Oh, this one. Interactive. Okay. Play.
Play all?
Play. When you get a play. One case, I will present it in 1 minute. Into, yes. Play. If you see play. See something, play this one. Last one. Okay, I will go quickly. This is 80 years old male. He came with left ventricular failure. He had severe mitral regurg. Clearly, you can see myxomatous mitral valve with severe MR, with significant pulmonary hypertension. So he underwent surgery in our hospital, mitral valve repair. Okay, this is before surgery, severe MR. Oh, no, this is not the one, huh? No, oh, not this one. Yeah, this is the one.
أيوه.
Anyhow, this is a patient who had mitral valve repair, and he had severe SAM with LVOT. Okay, so this is the first echo intraoperative TEE after mitral valve repair. You can see significant SAM with significant LV turbulence here. Yeah, you can see both the posterior leaflet, the anterior mitral leaflet is long, and so what the surgeon should do? I did not accept this LVOT obstruction. I told him this is significant LVOT obstruction, significant SAM. So he took the patient back to the pump, and he did one step. Yeah. So he did one step. So what is that step? No. We use all the tricks. It didn't work. Hmm? No. No.
عمل مايومكتومي ولا ايش؟
No.
Stop the inotropes.
He stopped the inotrope. He gave fluid, beta blocker, all the tricks. The gradient was still there. He did surgical maneuver. He did what we call sliding annuloplasty. So he make it smaller. So يعني the problem is the posterior leaflet is very long, and the anterior is also long. So this is a predictor for SAM after repair. So he make the posterior leaflet short, very short. Then the SAM disappear and patient did well. Thank you
يعطيك
very
العافية
much.
دكتور. Thank you so much. Thank you, Dr. Mustafa. We'll move next to the role of echo in oncology patient مع الدكتور دكتور عبد المجيد consultant in King Fahad Special Hospital في الدمام. تفضل دكتور.
السلام عليكم ورحمة الله وبركاته. Thank you, Dr. Jamila. So today I will present, inshallah, in probably 10 or 12 minutes, the role of echocardiography in oncology patients. So I will talk briefly about the epidemiology of chemotherapy-related cardiac dysfunction, different complications of chemotherapy on the heart, definition and types of chemotherapy-related cardiac dysfunction, assessment of LV function and chemotherapy, and role of strain with chemotherapy, and diastolic dysfunction and RV dysfunction during chemotherapy. So generally, data are lacking on chemotherapy-related cardiac dysfunction. It's estimated that incidence is about 3% on those patients who receive a cumulative dose of anthracycline of 400. This increases to about 7 to 18% on higher cumulative doses of anthracyclines. But in oncology studies, the prevalence is significantly higher. The report says that it's probably more than 50% of cancer survivors exhibit some degrees of cardiac dysfunction. And after 10 to 20 years of chemotherapy, 5% of those develop overt heart failure. There are different complications, and all comes under name of chemotherapy-related cardiac dysfunction. One of them is the myocardial dysfunction with heart failure, which is the commonest, and we all know about it, related to anthracycline, anti-HER2, the vascular endothelial growth inhibitors, cyclophosphamide, and others, vasospasm and vasoocclusion resulting in angina and myocardial infarction, valvular heart disease that is caused by radiotherapy, arrhythmias, which is also caused by anthracyclines and TKIs, arterial hypertension, which is by vascular endothelial growth inhibitors, peripheral vascular disease, and pulmonary hypertension. So if we come to the definition of cardiac related chemotherapy, cardiac dysfunction, we see like a lot of definition in multiple trials. And they all play around with main thing is the drop in ejection fraction, ranging from 45%, 55%. The definition from ACC is a definite cardiotoxicity if you have a drop more than 10% and percentage value of 50%. This definitions in European is 53%. And probable subclinical cardiotoxicity if we have a decline by more than 10%, but the value is higher than 50%, with an accompanying decrease in GLS more than 15%. And the possible subclinical cardiotoxicity if we have a decline less than 10% and to a value less than 50%, or a GLS drop of 15%. This value also is 12% in European guidelines, but they are all comparable numbers. We have to recognize two types of chemotherapy-related cardiac dysfunction because their prognosis, their pathophysiology is different, and the treatment and the way we deal with chemotherapy-induced cardiomyopathy is different. So doxorubicin, which is the anthracycline, type 1, and trastuzumab, which is anti-HER2. So in anthracycline, usually new onset of heart failure and LV systolic dysfunction. So usually those patients comes with symptoms, while in anti-HER2, usually they are asymptomatic. And the dose effect is usually cumulative, dose dependent, while it's not an anti-HER2. And the clinical course may stabilize with heart failure therapy, but underlying myocyte destruction is irreversible. And that is the main thing about the anthracyclines. While in anti-HER2, trastuzumab, usually it's reversible. And if you re-challenge them with medication, then usually they go back. But with type 1 or anthracycline, if you re-challenge them, they will go into overt heart failure again, because as we said, it's irreversible. So if we come to LV function assessment, estimating LVF is not supported, and mainly because this is because it lacks reproducibility, even intra-observer reproducibility. So the recommendation is to do 2D volumetric symptoms method, which is from 2 planes. 3D EF has superior reproducibility compared to 2D. However, it remains sensitive to image quality. And the 3D echo, many advantages. It's accurate, it's reproducible, it assumes no geometric assumptions, and it minimizes the foreshortening, and it's automated, which makes more reproducible. The main disadvantage that we have is it's, again, based on the image quality that you have. And if we see that the accuracy compared to the cardiac MR, it's very accurate with the 3D more than the 2D. So usually what we do when 2 contagious LV segments of any apical view is not seen well, usually contrast is recommended, and it should be given in every sequential imaging after that. And giving unknown effect of the 2D speckle tracking, contrast images should be obtained first before giving contrast. And since diastolic dysfunction can precede the systolic dysfunction, so in some patients, full diastology should be done at baseline and all sequential imaging. GLS and chemotherapy-related cardiomyopathy, I will not talk much about what it is because it's already covered by other colleagues. But I will say that strain is the change in the length of myocardium or deformation, and we usually take the longitudinal strain, not the circumferential or radial, because longitudinal strain has been validated that is very reproducible, unlike the circumferential and the radial strain. And the value have been different in many studies, but generally a normal GLS is negative 17% in males and 18% in female. Generally, in adults, less than 16% is considered abnormal. 16 to 18% is borderline, and more than 18 is normal. And more than 15% change is known to predict subsequent decline in the EF. So first, this GLS story started a few years back, where small studies were going on to test the GLS in chemotherapy-related cardiomyopathy. But then Dr. Thavender Nathan had a systemic review in 2014, 13 peer-reviewed publication involving approximately 384 patients with anthracycline mainly. And they concluded, in absence of reduction of EF, GLS between 9 and 19% seems to be common during or immediately after anthracycline therapy. And they concluded also that early fall on GLS between 10 to 15% predict subsequent cardiotoxicity. But then this is the trial that the same guy published 2 years back, 2021, and it is the biggest and the only randomized controlled trial that we know in cardio-oncology. And it was international, multi-center, prospective randomized controlled trial, 331 patients treated with, they have one risk factor at least of heart failure, and they were allocated to either to have cardioprotective therapy initiation that is guided by either a drop in GLS or drop in EF, and they wanted to see whether those patients have, at the end, better systolic function. And at the end, 307 patients were analyzed in the study. And the majority of them were women with a breast cancer, and the primary outcome is, which is the change in the EF, was not significant between the two arms. However, in one of the secondary analysis, patients who received cardioprotective therapy in EF-guided arm had larger reduction than GLS patients.
2 minutes, Doctor.
Okay, so generally there was, in this study, there was one thing that draws the attention. Fewer patients met the chemotherapy-related cardiac dysfunction in the GLS-guided arm than the EF arm. And this was a surprise because we thought that we will detect with the GLS more patients that is going to heart failure than those patients who were detected by seeing the EF. And also in this study, part of the definition is drop more than 5%, but those change could have been possibly by error. So the message from SOCOR trial to the moment, we do not depend on the drop of GLS alone to start medical therapy, and we do not depend on drop in GLS as a sole factor to stop chemotherapy. Generally, we recommend referral to cardio-oncologist, and discussion between cardiologist and oncologist encourage if there is no cardio-oncologist in the institution. And further trial had to be focused on clinical endpoints. If we talk about LV diastolic dysfunction, this meta-analysis concluded that there are no data to support their use as a predictor for heart failure in treating the patient with heart failure, chemotherapy. And also RV dysfunction happens usually in RV biopsies that in those patients who are treated with chemotherapy. However, there is no data about it. Okay. I think probably this is the last slide.
Time is up, فيمكن علقت
That's fine.
Thank you.
Thank you very much indeed for all the speakers. I think in the sake of time, there will be no discussion. We will conclude the session and we will move to the following session. Thank you so much.
وكان الفايد دكتور محمد الراوي. دكتور محمد الراوي. Not here. دكتور الراوي. دكتور سارة, can you help us? لا 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 موجودة هنا.
في اول واحد وبعدين زكريا.
التركيب
عند الجدول انا خلاص على ما عندك الجدول. جميلة.
الو.
جميلة اللي هي اول واحد منه. في عيادتي.
كل واحد 12 دقيقة كيف على السريع.
من
اوكي. 12 دقيقة.
طيب.
ما يحتاج اقول لك تضيع وقت هذا. It's not important. خلينا نديهم للدسكشن بس يسمعوا.
ومفيش discussion.
Hello, assalamu alaikum. We'll start the session by Dr. Minwar al-Majnouni. He's a consultant cardiology and echocardiographer, head of the HIS Implementation Steering Committee. He's the head of Saudi group of echocardiography, and he will talk about neuropathy. Dr. Minwar.
شكرا دكتور مصطفى. السلام عليكم. I'm going to talk about a subject that is came late. I hope to just refresh our information regarding this subject. Constrictive and restrictive pericarditis. Actually, two entities, and it's a type of diastology dysfunction, actually. But usually we sometimes we don't pay attention for the Doppler studies, and we sometimes miss to catch up with this finding. So today I'm just going to have, like, study together the causes and how to identify them by echo. So constrictive pericarditis is a pathological condition with encasement of the heart by thickened, fibrous, and sometimes calcified pericardium, with secondary abnormalities in the chamber filling. Constrictive pericarditis itself is a potentially reversible cause of as I said, diastolic dysfunction, and there is three conditions resembling this condition: tricasp valve, regurgitation, and restrictive cardiomyopathy as well. So the clinical picture is heart failure, but the finding is different. So we need to be precise to identify the cause of this diastology. Remember, usually when we talk about constriction and restrictive, we have to think about two things. One is, in case of constrictive, it is a stiff wall. What I mean is the pericardium is so stiff that restricts the filling of the cardiac cycle during diastology. While in the restrictive dysfunction, it is in the muscle itself. So total different in the pathophysiology of this. But both of them lead to a reduced filling in diastology. That's why the preload is affected, so the afterload is affected as well. So etiology, when we study the constriction, we think about many causes like, infection, cardiac surgery, radiation, and so on. Dr. Lang and his group, they studied the causes in two periods, actually. They divided two groups and finding what's the reason behind this situation. The first group this is a retrospective studies. They want to find what the cause behind this. So in 1936 to 1982, they found that the most common cause of the constriction is infection. Okay, and the second was the radiation cause. But in 1985 to 1995, they found that the first cause is idiopathic, and the second place came the surgery, post-cardiac surgery. And so on, the radiation and infection comes after. Now, it's the time of the echo. The first finding in the 2D in diagnosing the constriction is what we call it ventricular interdependence. And this, you can see it very clearly by 2D of the getting the fourth chamber. Sorry. Go back. As you can see, sorry. Yeah. As you can see, the interventricular septum, an inspiration move to the right, left ventricle, and expiration right ventricle. And as well, you can find this finding by doing the M mode of the left ventricle. As you can see, the ventricular septum moving with inspiration toward the right ventricle, and with to the left ventricle, and with expiration to the right ventricle. And again, you can find it what we call a septal shudder, which is a septal diastole shudder consistent with the septal bounce seen by the 2D. Step 2, you will do the Doppler study of the mitral inflow, and you can see the variation of the flow, and this variation, it has to be more than 25% of the normal with the respiration. So the point of to have diagnosis of this, you need to set up the spirometer with the Doppler study. It's very important. The third step is to make the tissue Doppler of the medial mitral annulus and the lateral mitral annulus speed. So you'll find in the medial mitral annulus tissue Doppler demonstrate elevated E prime despite increased filling pressure, and we call this annulus paradoxus. While the lateral mitral annulus speed, it is less than the medial, and we call it annulus reversus due to the lateral tethering of the part of the mitral annulus because of the constriction. The tissue Doppler, as you can see again, it is the same. You see that the lateral is less than the medial. And the other point that can give a clue of the constriction, you might find the thickening of the posterior wall by the 2D, and if you did a chest X-ray, you'll find a calcified pericardium. Next step is doing the Doppler of the hepatic vein and inferior vena cava. You can find inferior vena cava dilated, fixed dilatation with loss of collapsibility. And when you study the Doppler velocity of the hepatic vein, you can see, as you can see, the D signal is less than with the expiration, the flow is less than the inspiration. So there is a variability during the inspiration and expiration with the atrial reversal signals with expiration. And Doppler over the pulmonary vein as well, as you can see, it's as well as the mitral annulus flow. You'll find variability of the filling of the pulmonary vein. Sometimes you suspect the constriction, but it's not obvious with the mitral flow, and you might do this maneuver, sitting position, and you measure check for the variability of the flow over the mitral in the sitting position. So, is the tamponade caused by pericardial effusion gives the same picture of constrictive pericarditis? There is? How far similarity? Is it the same or different? Because most of, both of them, there is constriction, right? There is restriction of the filling. Well, tamponade in the physiology resemble the constriction, but it differs. With the constriction, early diastolic filling is rapid, but end abruptly when the volume limit, the rigid pericardial space are reached. While in tamponade, the diastolic filling is impaired in both early and late, as you can see. Restrictive, the second entity of studying the diastology is restrictive cardiomyopathy. And as I said, restrictive cardiomyopathy is a primary disease of the myocardium itself, and it's caused by abnormal elastic properties of the myocardium and or intracellular matrix. The presence of abnormal left ventricular diastolic filling associated with intracellular and or interstitial infiltration or fibrosis in the absence of LV dilatation. We have many causes for the causing the restrictive cardiomyopathy. We have familial and genetic disease and non-familial, non-genetic disease. The familial, like the sarcometric protein mutations, familial amyloidosis, and so on, primary hemochromatosis, and glycogen storage disease. Non-familial, we have the amyloidosis, which is acquired, idiopathic, and sarcoidosis, scleroderma, hypereosinophilic syndrome, idiopathic, and drug like methyl sergide and ergotamine, and so on. Carcinoid is one of the causes of the restrictive cardiomyopathy as well. Metastatic cancers as well, radiation, chemotherapy. We'll come to the point of diagnosing the restriction by echo. One of the hallmarks of diagnosing the restriction is the typically cardiomyopathy characterized by a marked dilatation of both atrias in the presence of normal or mildly reduced LV function. As you can see, the mitral flow is having distinctive increase of EA ratio. It should be more than 2, with short E-wave deceleration time and mostly less than 150. The lateral mitral annulus, as you can see, the speed is very slow in compared to the other type. It should be less than or mostly less than 5. And as you can see here, it is 4 centimeters per second. In hepatic vein Doppler, as you can see, the diastolic variation with respiration. Can you give me 1 minute? Just 1 minute. Wasta.
I think time is up, so just
30 seconds. I want to put just 30 seconds.
Okay, 30 seconds exactly.
If you have mitral inflow ratio more than 8 and dilated IVC, so this is unlikely to be, if you don't have it, unlikely to be constriction or restriction. If you have it with ventricular septal defect, you need to measure the E prime over the mitral. If it is more than 8 centimeters, it is constrictive. But if it is 6 to 8, this is mixed. You need to do further testing. And lateral, if it is less than the medial, so this is mostly constriction. And if the hepatic vein dilated more than 8, so it is definitive constriction.
Thank you very much. I think we'll move to the next talk, which will be virtual. Dr. Kostas Babadelios from Greece. He's going to join us. He is well known in the field of echocardiography in Greece. He has been published many publications. He had been certified. Dr. Kostas, are you with us? We can't hear you. Unmute yourself, please. Is he with us online? Dr. Cordes, can you please? We still can't hear you.
Until I chat him, I'll have a chat with him. We'll go for Ms. Huda.
For the third? Yeah. Okay, till we sort his connection, we'll go to move to the next speaker, Dr. Huda Shahata. Dr. Huda is a consultant echocardiography from Alexandria and has been worked before, and she got her PhD from Padua and King College. She's going to speak about the role of 3D in left atrial appendage closure. So, Dr. Huda, the floor is yours. Please stick to the time of 12 minutes. I knew in the schedule all of the speakers are supposed to have 15 minutes, but this is the recommendation of the organizing committee.
Okay, I'd like to thank our dear Professor Dr. Ali and the Almoosa Hospital for the great invitation to be sharing in that great Congress. So my talk today I'm going to talk about the role of echo in assessment of patients going to do percutaneous left atrial appendage occlusion. First of all, I have nothing to declare. So here we are going to talk in my presentation about the role of TOE in assessment in those patients. We have to understand the anatomy of the left atrial appendage. We have to understand the proposed TEE protocol and the imaging views. What is the role of the transesophageal echo in assessment of that left atrial appendage, the procedural guidance and the possible complication, and finally what we have to do in the follow-up of those patients. First of all, the left atrial appendage actually has its own personality. It has multiple common nominations. We have the windsock type, and also we have the chicken wing, the cauliflower type, and also we have the cactus shape, which is more described in the cardiac CT. However, this is not important because sometimes we have atypical or non-identified shapes of the left atrial appendage. Sorry, please. It's a freeze. It's not going on. Yes. What's more important, the left atrial appendage, is to know the number of the loops because it's a complex multi-looped structure, to know the anatomical boundaries, what are the imaging plans, to rule out presence of clots and to assess the contractile function using the emptying velocity. First of all, here all of us use TOE for assessment of the left atrial appendage. As we can see here, the blue rounded circle at the bottom of the image, this is where the TOE probe sits. Here we can see that the left atrial appendage is the furthest away structure away from the probe of the transesophageal echo. It's sharing common boundaries with the aortic valve, aortic root, mitral valve, and also with the left superior pulmonary vein. In another imaging plan here, we can see this is the probe of the transesophageal echo, and again, when we scan the left atrial appendage from this plan, we can see here that the left atrial appendage is correlated with the left upper pulmonary vein and with the pulmonary artery, as seen here in the CT. So there is liability for perforation, sometimes in laterally located left atrial appendage of the pulmonary artery. Here, what are the different or the parts of the left atrial appendage? Here we can see this is the ostium, and this applied to any shape of the left atrial appendage. This is the ostium or the orifice of the left atrial appendage, and then come the landing zone, which starts at the important landmark, which is the left circumflex artery here. And this is important for determining the size of the left atrial appendage occluding device. And the distance from the orifice to the landing zone, this is the neck of the left atrial appendage. And finally, which is important for choosing the size of the Watchman device, is the depth of the left atrial appendage, which starts from the landing zone till the apex of the left atrial appendage. So, what are the important landmarks that I have to check before going for left atrial appendage occlusion? First, which is the Commoden ridge or the warfarin ridge, limpus or Q-tip as it's called in Australia and USA. This is the lateral boundary of the left atrial appendage, and usually it separates the left atrial appendage from the left upper pulmonary vein. Here, this is formed the superior ridge of the left atrial appendage as seen in the 3D echo. And also one of the fundamental boundaries of the left atrial appendage, which is the left circumflex artery originating from the left main coronary. And this is an important landmark for assessment of the landing zone, as we will show later on these slides. Also, we have here the mitral valve here. It's important that the device is not impinging over the mitral valve leaflets. And this is the interatrial septum, which is important for the transseptal puncture when introducing the device. So there are 4 specific planes in the TOE to look at the left atrial appendage. The first one, which will be at 0 degree. Here we can see this is the most anterior view of the left atrial appendage. We can see the aortic valve and the pulmonary vein here. And one of the most important, and this is the most important view to assess the size of the device, the landing zone and the depth of the left atrial appendage will be at 45 degrees. Here we can see clearly the left circumflex artery, the Commoden ridge, and here we can see the maximum long axis, and we can assess the depth of the left atrial appendage. Also at 90 degrees here, we can see that the aortic valve will disappear and mitral valve come in view. We can see the Commoden ridge, the pulmonary vein and pulmonary artery. And finally, the next important view to assess the left atrial appendage will be at 135 degrees. Here we can see that the orifice here has a different size from the orifice here, as we will see later on. And we can see the circumflex appear, the Commoden ridge and the pulmonary artery is correlated well with the left atrial appendage. So, what is the important view that we are going to use during implanting our device? We have to use the X-plane or the biplane mode if you have a 3D-enabled machine. Here at 45 degrees, we can see this is the lateral boundary of the left atrial appendage formed by the Commoden ridge, and this is the medial boundary containing the left circumflex and the lateral annulus of the mitral valve. In the other orthogonal view, we can see the left atrial appendage in anteroposterior direction, and it's related to the pulmonary artery. Actually, this is a standard view to assess the landing zone, the ostium, and the depth of the left atrial appendage. Why it's always, it's a freeze again. It's not working. لسه تحت خلصنا كل ده كمان. Oh yes. Okay. Let's go for the procedural guidance here. The TOE is a standard technique that's used to rule out thrombus. Be careful, because the patient referred for left atrial appendage occlusion, they are usually not properly anticoagulated, because either they have contraindication to anticoagulation or they have bleeding complications. So look carefully for thrombus in these patients. You can use the biplane or X-plane. You can use the color Doppler flow, but be careful that you should lower the color scale because it's a low flow chamber. Use the emptying velocity at the orifice of the left atrial appendage. Use contrast and give time for the contrast to fill inside the left atrial appendage. And also, we have to check it. لا في حاجة شكرا. Look carefully in these patients. You have also to rule out, especially in patients with dense spontaneous echocontrast or left atrial appendage, sludge or mud inside the left atrium or appendage. Be careful in those patients, because sometimes you have a clear appendage. However, we have a large thrombus, like in this patient, hanging over the roof of the left atrium. This is a patient that has a large left atrial appendage thrombus here, seen in different plans and in the MPR. And also, this is the most huge left atrial appendage thrombus I have ever seen. This is actually not patient referred for left atrial appendage occlusion, but the patient came with prosthetic mitral valve thrombosis, and we accidentally discovered this huge thrombus inside the left atrial appendage. So the most important part in this lecture is to what about the device sizing in those patients. We can do device sizing using 2D or 3D TUE or cardiac CT. If we are going to use the 2D TUE to size our patients or occluded. In amulet type, here, the standard view is at 45 degrees. We have to obtain 3 measurements, which is the orifice here, which stand at the ostium of the left atrial appendage, and then we go from 10 to 12 millimeter inside the depths of the left atrial appendage, or the best is to start at the left circumflex artery, and we go across the appendage to the other side from 1 to 2 millimeter inside the appendage, and this is the landing zone, and it will determine the size of the device that I'm going to use. And finally, the depth of the left atrial appendage, and it should be from 10 to 12 or 15 millimeter in length. This is regarding the amulet type. What about the Watchman type? In Watchman device type, here we forgot or we ignore the orifice measurements. We have to do 2 fundamental measurements here, which is the landing zone at the level of the circumflex artery, like in patients going with amulet. But the most important here that we measure the left atrial depth. And in patients going to have a Watchman device, we should have a depth which is equal or greater than the landing zone in those patients. So this is using 2D. What 2D transesophageal echo? What if I'm going and I have 3D TUE? Be careful, because 3D TUE is important in those patients, because the orifice and the landing zone, as we can see here, it's not a quite well circle. We have an oval shape with maximum and minimal diameter. Also, we have a spiral configuration, as we can see that the upper border here at the limbus has higher level and goes spirally downward to the inferior margin. So we have different plans at the ostium of the left atrial appendage. So here, the 3D transesophageal echo can help to avoid undersizing of the device. So with the help of the 3D MPR, we can assess the left atrial appendage orifice here and get the maximum and minimal diameter. And also with the help of the multiplanary formatting, we can go down at the level of the circumflex artery and get the maximum and minimal diameters of the landing zone. So which diameter I should use in those patients, the maximum, the minimum, or the average? Actually, it depends on the type of the valve, the device. If I'm going to use amulet, okay, okay, هتقف ولا؟ Okay. If I'm going, sorry, okay. If I'm going and I obtain the maximum and minimal diameter, if I'm going to implant an amulet device, I will take the average of the maximum and minimal diameter. But if I'm going to use a Watchman device, I usually oversize by 10 to 20% of the actual size of the left atrial appendage. So we choose the maximum diameter to get the size of the Watchman device. Here is there are available charts and tables for appropriate sizing, but be careful. According to the last consensus on the catheter-based left atrial appendage occlusion, amulet device is not used if the patient has a landing zone more than 31 millimeter, and if the depth of the left atrial appendage is less than 10 millimeter. So what about the Watchman device? The Watchman device, we have to be careful, as we mentioned, that the left atrial appendage device, Watchman device, cannot be used when the left atrial appendage depth is less than the diameter of the landing zone. When we go the next step, here we choose our device. We have to go to the transseptal puncture to go to the left atrial appendage. And we know, all of us, that the left atrial appendage is an anterolateral structure. But in some patients, it can be more laterally or more anteriorly oriented. In those patients, how I know that it's more anteriorly directed more than being laterally directed? When we see the long axis of the left atrial appendage and the aortic valve in view, this means that this left atrial appendage is more anteriorly directed. So I have to puncture the septum more posteriorly. And if I have the maximum long axis of the left atrial appendage while the mitral valve in view, so this means that the appendage is more laterally directed, so I have to puncture the septum in the middle or a little bit anterior. Here, this is again the standard view for the transseptal puncture. I have to obtain a standard bicaval view, the superior and inferior vena cava, and also the short axis view with the aortic valve in view. This is the anterior and this is the posterior part. Here in the superior inferior configuration.
دكتورة هدى المحاضرة رائعة ومستمتعين but we have really to
طيب اوكي ثانك
قولي لنا لا قولي لنا message take home في ثانيتين.
Take-home message TOE is the standard technique actually to size the device that I'm going to implant regarding the type and the size of the device. So this is important in guiding the procedures, rule out complications, and also in guiding the transseptal puncture. And also it's important to be in the posterior and inferior part of the interatrial septum. Follow-up imaging of those patients is important because they have sometimes leaks to check at the 3 months, 6 months, and 12 months. Thank you.
شكرا جزيلا دكتورة هدى. Do we have Dr. Costas with us? Dr. Costas, how are you? Thank you very much. Can we? Yes, we hear you, but we don't see your slide. Take your time. I already introduced you to the attendee here.
Great.
Now we can see you and we can see your slide. Just put it in the show mode. Great. Thank you very much. You can go ahead now. The floor is yours.
Thank you. So I'm honored by your invitation to attend this Congress, and congratulations for the nice topics. In 15 minutes, we will talk about how to assess the mitral valve with stress echocardiography in this lecture. These are my disclosures. So we all know that with the 3D echocardiography, we can appreciate large anterior, one smaller posterior, the scallops, and have this nice surgeon's view of this mitral valve. And we should all know this Carpentier classification, distinguish the primary from secondary MR, and know the pathophysiology of mitral regurgitation in order to have a common language. There are standard methods for quantification of the severity of MR. We usually go with the PISA method to measure the recursive orifice area and the recursive volume, but we should also use the color Doppler, the vena contracta, the pulmonary veins flow for systolic reversal, and if we have a 3D probe, then we can also measure the vena contracta area. In the last ESC guidelines for valves, we know that the threshold for severity of MR is equal in primary and secondary MR, and now we should report a severe mitral regurgitation only when we have an ERO more than 40 millimeters square. And of course, we should never forget the qualitative criteria of severe mitral regurgitation, for example, like a flail leaflet. In terms of management of these patients, we all know that if we have a severe MR and the patient symptomatic, then we should repair this valve, either surgically or with transcatheter edge-to-edge repair if the patient is high risk. And this is in agreement between ESC and American Society. But what happens if we have this subgroup of patients? A patient with severe MR but claims to be asymptomatic, or a patient with symptoms of heart failure and moderate MR. In these situations, we can use stress echocardiography because stress echo can answer questions like what is the severity of MR if the patient is truly symptomatic, what is the systolic function of the left ventricle, and what are the pulmonary artery pressures. Stress echo is not only for ischemia detection, we can also use it for non-ischemic heart disease. This is a consensus document from ECBI showing that we have an algorithm where we can use exercise echo in patients with discrepancy between the symptoms and severity of valvulopathies. And in primary and secondary MR, the indications for exercise stress echo are symptoms disproportionate to MR severity, recurrent and unexplained pulmonary edema.
Dr. Constantinos, can you please come closer to your microphone? Because we are having difficulty to hear you. Great. Yeah, you can speak now. So.
Yeah, what about now?
Yeah, I think it's better. Go ahead, please. Thank you.
Okay, so I was saying that the indications for stress echocardiography in primary and secondary MR are symptoms disproportionate to MR severity, recurrent and unexplained pulmonary edema, patients with moderate MR that undergo CABG, bypass surgery, and persistent pulmonary hypertension in patients after mitral valve repair. We should all know that 1/3 of the patients that claim to be asymptomatic usually modify their habits and lifestyle in order to avoid their symptoms. This is something that we should know for all asymptomatic patients. In our lab, we have a supine bicycle, and this is the stressor of choice because with supine bicycle, we have a reduced risk of hemodynamic collapse. We can have continuous echocardiographic examination throughout all stages. Cycling is more isometric than walking on treadmill, and the patient remains at the same position throughout the whole examination with echo. There are several protocols for exercise echo, but all of them agree that if we use an exercise echo with bicycle, then we can have 2-minute stages of 25 watts each stage, and in every stage we should assess the left ventricle diastolic and systolic function and wall motion abnormalities, the right ventricle, the mitral valve, either MR or mitral stenosis, the E2E prime and diastolic dysfunction, the TR velocity and the pulmonary pressures of these patients. All these measurements should be done in every stage during stress echocardiography. Parameters of poor prognosis in primary MR are increase of MR grade more than 1, pulmonary systolic pressure more than 60, absence of contractile reserve, which means less than 5% increase of ejection fraction and less than 2% increase of GLS, and limited RV contractile recruitment, which means that TAPSI less than 19 millimeters during exercise. And in secondary MR, parameters of poor prognosis are increase in ERO more than 13 millimeters square and significant pulmonary artery pressure during exercise. Reserve of the patient, measure the ejection fraction during exercise and the GLS. The patients without contractile reserve are the ones that had major events, and patients with less survival in a period of 3 years follow-up in this paper. And of course, right ventricle is also important. Right ventricular dysfunction during exercise is very important because it is a prognosticator for poor prognosis and survival, and prognosticator of heart failure hospitalizations in these patients as well. In secondary MR, a difference of ERO more than 13 millimeters square is important because this can show the heart failure admissions of these patients and the survival as well in secondary MR. Pulmonary hypertension should also be measured in patients with secondary MR. You can see in this slide that the patients that develop severe pulmonary hypertension are the ones that have increased major adverse events, hospitalizations, and decreased overall survival. So all these are included in the new guidelines from ESC for valves, and in these guidelines, the stress echo is used in primary MR in order to unmask the symptoms, or if we have difficulties in diagnosis with the resting transthoracic echo. And in secondary MR as well, stress echocardiography can be used if the resting echo is inconclusive. So let's check some cases, different clinical scenarios, patients that came to our lab for exercise stress echocardiography. So in the first case, we have a 70-year-old female patient, smoker with diabetes mellitus, a recent inferior STEMI with primary PCI, moderate ischemic MR with akinesia of the inferior wall, and heart failure symptoms of NIHA class status of 3. The baseline transthoracic echo showed the akinetic inferior and inferolateral wall and a moderate MR with normal pulmonary pressure. So the patient was referred to our department for exercise echo. At rest and baseline transthoracic echo, you can see a preserved ejection fraction, a moderate MR, diastolic dysfunction grade 1, and ERO of 10 millimeters square, a GLS of minus 16.7, and normal pulmonary pressures. So we did exercise echo, and at the second stage, in 50 watts, you can see that we had a significant mitral regurgitation with an ERO that was increased at 30 millimeters square. We had significant LV filling pressures. The patient was symptomatic, but we didn't have severe pulmonary hypertension, and we had a very nice contractile reserve with GLS of minus 19%. Since we did a TOE in the patient, we saw that the valve has no anatomic abnormalities. We had tethering of the leaflet, so it was an ischemic MR only, but significant MR. But since the patient was very close to the STEMI, we decided to wait, see if we have a resolve of this akinesia of the inferior and posterior wall, and if the tethering becomes better throughout the follow-up visits. So the patient came 6 months later. You can see that the wall motion is better now, and the patient felt better as well. She was on NIHA status 2, and the MR was still moderate. It didn't increase, so we decided at the moment not to do anything in this patient and just watch and wait. In another clinical scenario, a young patient, 49 years old, with heart failure symptoms, shortness of breath, NIHA class 3 status. He came for a transthoracic echo. We saw that we have a prolapse of the posterior leaflet, normal pulmonary pressures, increased LV filling pressures, so we decided to do an exercise echo in order to evaluate the MR severity and the pulmonary pressures of this patient. You can see at the baseline transthoracic echo that we have this very eccentric jet of the MR. We have a prolapse of the posterior leaflet, a coaptation gap, which means that probably it is a severe MR. The TR velocity was 2.8, and the ERO was measured at 10. Again, we underestimate the ERO when we have that eccentric regurgitant jet. We did an exercise echo. We saw that the Pisa radius and the ERO was measured at 40 millimeters square. We had a TR velocity of 3.4, a restrictive pattern of mitral valve inflow, systolic reversal in pulmonary veins. So we confirmed the presence of severe MR, and the patient was symptomatic at a level of 100 watts, with contractile reserve also, and the normal right ventricle. So we did a TOE, and we saw that we had this flail P2 scallop with ruptured chordae of the posterior leaflet, so the patient underwent a surgical mitral valve repair. Another symptomatic patient now, an old male, 76 years old, symptomatic heart failure symptoms with moderate degenerative mitral regurgitation due to prolapse of the posterior leaflet, normal ejection fraction, normal pulmonary pressures, normal LV filling pressures. So does he have symptoms due to the MR or not? We did an exercise echo again in this patient. You can see here that we have an enlarged left ventricle, an eccentric jet of MR in this patient, normal E and A waves, TR velocity 2.4, and at stress we couldn't appreciate the ARO because the jet was so eccentric, but we had increased LV filling pressures and the TR velocity went up to 3.7. The patient was symptomatic in 50 watts very early, only with 2 minutes of cycling. So we did a TOE and we saw that we had this multiple chordae ruptured at the level of P2 scallop and this prolapse of the P2 scallop. So we decided with this symptomatic prolapsed valve to proceed to surgical mitral valve repair. Sometimes you might have a young patient like this male, 52 years old, with severe MR, flail leaflet. He claimed that he didn't have any symptoms. He didn't want to do anything for the management of this valve. So he came for an exercise echo in order to unmask the symptoms or not. You can see at the resting TTE that we have a flail posterior leaflet, significant MR, severe, and pulmonary pressures 2.6 with 75 watts of stress. We can see that we had severe MR, severe TR, restrictive pattern of mitral valve inflow, and TR velocity 3.9. The patient was really symptomatic. We had to stop this exercise. So he was convinced to undergo a TE. And you can see here again the flail P2 scallop with multiple chordae ruptured. So the patient underwent surgical mitral valve repair. Sometimes we can have a non-obstructive hypertrophic cardiomyopathy case.
Dr. Constantinos, we have only 1 minute, please.
1 minute, yes, I will conclude. In this case, sometimes if you have a hypertrophic cardiomyopathy case, then you might have to answer if the patient has only diastolic dysfunction or MR. You can see here that this patient with exercise echo and mild MR with stress, we had a TR velocity of 3.5 and this systolic anterior movement of the anterior leaflet and this significant MR. But in this kind of patients, we only go with medication or with transcatheter edge repair, and we don't repair or replace the valve. Finally, in less than 1 minute, I will just tell you that when we have a mitral stenosis, the cutoff values for significant mitral stenosis in exercise are 15 millimeters of mercury in exercise echo, or if we use dobutamine, then the mean gradient of mitral valve should go in 18. Like in this patient, you can see the rheumatic mitral valve with doming of the anterior leaflet and a mean gradient from rest at 7, it went up to 22 with 2 minutes of exercise in a symptomatic patient. So this was confirmed, of course, with TE. Flexi-slice measured the mitral valve at 0.9 centimeters square. So it was a confirmed severe mitral stenosis case. So I conclude with this slide saying that exercise stress echocardiography is very important for the timing of intervention and very important when we have discrepancy between the symptoms of patients and the severity of valvulopathies. And when we do a supine bicycle to our patient, we should not only examine the mitral valve, but also the left ventricle, the right ventricle, the TR velocity, and the pulmonary pressures. Thank you very much for watching. I hope I was in time. And I would like to welcome you all in our Imaging Congress in Athens, 31st of March. Thank you.
Thank you very much for this excellent lecture. We are looking to see you in Greece in next 2 months. Do you have any question? Yeah, go ahead, please.
Thank you for this nice, attractive lecture. I would ask about the priority of mitral regurg. If you see the second and third case you were present, the patient has flail lips. I think the T is priority, and we cannot, there is no clear guidelines about evaluation of the severity for intervention by stress echocardiography. This is my concern about this presentation.
Our experience, we can understand if we have a severe MR, because if you see a flail leaflet, then in my opinion, you don't need to do exercise echo. But sometimes, you know, if you have a patient that says that he doesn't have any symptoms and he's young, then these patients are very difficult to convince to proceed to surgical repair. And in these cases, the bicycle helped me to convince them that they have problem. They don't do what they used to do 1 year or 2 years ago. So, of course, in guidelines, it's not a priority. You cannot choose how to go step by step. But if you ask for my opinion, if you can see a flail leaflet, go for a TOE and surgical repair. But if you have a difficult patient, then you can convince him and mask the symptoms with a bicycle.
The next meeting. Thank you.
Congress, and thank you for the invitation.
I think the next speaker is Dr. Reem Al-Badr. She is a well-known consultant, professor of pediatric cardiology at King Abdulaziz University. Dr. Reem, she will talk about aortopathy in adult congenital heart disease.
Bismillah. Hello? Okay. Bismillah ar-Rahman ar-Rahim. Thank you so much for staying so late. And I'm really grateful, despite all what's happening, you're still staying. And I want to thank Dr. Ala for such a beautiful gathering. We haven't seen each other for 2-3 years or more than that since he stopped doing the ECHO meetings. Alhamdulillah, he's back. And also I want to thank Dr. Abdullah Al-Farhan for his really a lot of help and support to all of us. I'm going to switch gears to a different theme, which is the pediatric side of the disease, which is also the origin of all diseases that you see, most diseases that, congenital diseases that you see in adult life. So I have no disclosures. The definition, adults with congenital heart disease fall into 2 categories. One is that patients who have been recognized, treated, and followed during their pediatric years, and then we hand them over to you, or de novo previously unrecognized adults who may or may not be symptomatic at time of diagnosis. So we have 2, either follow-up or de novo. Now, prevalence and risk factors, congenital heart disease in the adult is now more prevalent than ever because of rapid advances, surgical medical interventions, because we are really doing a lot of preventive medicine, a lot of sort of scanning and so on. Now, this is very important. Now, there are now an estimated 750,000 adults with congenital heart disease in the US alone, and this statistics is not updated. Now, this is excluding the bicuspid aortic valve, which is very important. And I see even bicuspid aortic valve in utero. But we don't really say this is the commonest congenital heart disease. I don't know why. It's about present in the 2% of population. For us, the commonest congenital heart disease is VSD or PDA. And so we have bicuspid aortic valve and we have mitral valve prolapse. Prevalence and risk factors, most congenital heart disease appears to be caused by genetic abnormalities. Now, with the whole exome sequencing and a lot of genetics going on, most of the diseases will carry genetic origin, but there's difference between genetics and inheritance. We have to know that. So evidence to support importance of genetics in congenital heart disease includes much higher risk for offspring. Always mothers ask about, what about my kids? I have tetralogy. Will I get a child with tetralogy? I have transposition. I had transposition. Now, we're not talking about acquired mitral stenosis secondary to rheumatic heart disease. That's not part of the spectrum at all. Now, we always go and research into, we know that the incidence of congenital heart disease is 8 per 1,000, but in Saudi it's around 12 to 16 per 1,000. It's not documented, but 2 centers already published their data. And we have higher incidence of congenital heart disease because of the consanguinity that we have. Now, we know about familial congenital heart disease. This is very important. So there's difference between inherited heart disease and familial. Familial is more than just inherited. So it comes in the family because they don't, مو زي الرسول صلى الله عليه وسلم قال غربوا نكاحكم. They keep in one family or one tribe or whatever. Especially among the rich people, they don't want the money to go outside. It happens a lot. They keep giving their children. Now we talk about the common clinical syndrome. So please note that chromosomes is not always genetic. These are terminologies that we know as pediatricians. So we have 21, trisomy 21. We have 60% of trisomy 21, they have congenital heart disease, which is atrioventricular receptor defect, the majority. So if in a fetal life I see AV canal, I refer the mother for genetic testing, for chromosomal analysis for trisomy 21. And vice versa, if there is a fetus with trisomy 21, we have to do chromosome, we have to do heart. So we work as cardiologists and phytologists, we work very much with families and congenital heart disease. Anyhow, in general, routine screening of adults for genetic mutations is not currently advocated. It's not cost effective, okay? Especially in the West, and we follow the West. We don't have anything for the Middle East area or for the Gulf, where we say we have lots of things going on, cardiovascular diseases and long QT syndrome and familial long QT syndrome now, and I think in King Faisal they have a registry for that. But it's not all over the area. Pathophysiology. Now, we know that clinical course of congenital heart disease in the adult is most dependent on the anatomic lesions. What does this mean? If I have transposition of great arteries operated on the adult will look normal. His saturation would be around 92 to 94%. If I have a single ventricle and she's 22, and she has a Fontan and her, without fenestration, her saturation will be around 98, 94. With fenestrated Fontan, her saturations will be around 85 or 84. So it depends on the etiology, okay? Please don't consider mitral stenosis, mitral regurg, and rheumatic heart disease as part of the spectrum that I'm discussing. Now, lesions, we know that 3 general categories, just to refresh your memories, because you left the pediatrics long time ago. We have simple shunt lesions like ventricular receptor defect, patent ductus arteriosus, and so on. We have obstructive lesions, like aortic stenosis, pulmonary atresia, and so on. We have complex lesions, acyanotic and cyanotic. Cyanotic, we all know about the obstructive right heart, obstructive left heart. Acyanotic, we have like AV canal. Most of the time it could be cyanotic, but very little cyanosis or total anomalous pulmonary venous return, and so on. These can be missed. Now, genetic aortopathies. We're going to focus on the aorta now. And we talk about the genetic etiology of aortopathies that you see in adult life and we deliver to you. So we have, as we said, autosomal dominant, which is Marfan. Autosomal dominant means mother and father are carriers, 50%. And with every delivery, there is 1 in 2 chance that the baby will carry the disease, so 50%. So when we counsel a pregnant mother with a Marfan syndrome fetus, we say, with a fetus, we say there's a 50% chance that your baby will be a Marfan. Marfan, Ehlers-Danlos, and Lewis-Teeth syndrome. So remember Dr. Hani Mahmoud was showing his fingers and he was doing like that, and somebody asked him if he is a Marfan syndrome or connective tissue, because they have elasticity, and not every Marfan is I mean, we have lots of them. Marfan, Ehlers-Danlos, and Lewis-Teeth, they are connective tissue disorders with increased elasticity, but have other phenotypes with it. Aneurysms of the osteoarthritis syndrome and Turner syndrome. Chromosomal is these are the short ladies with XO, so they don't have a Y, so I have a 0 or instead of the Y. So it's instead of the X, sorry, XX, you had XO. And these are short women, and these are chromosomal abnormalities. Any lady below 150 should be screened for Turner syndrome, and you usually do a buccal smear, and it's very easy to diagnose. Non-syndromic familial thoracic aortic aneurysms and dissection. So non-syndromic because in children we have lots of syndromes, lots and lots of syndromes, and when we say syndromes, it doesn't mean that these are inherited things. These are just phenotypically with structure abnormalities, constellation of symptoms, and we call it syndromes. So non-syndromic and familial. So familial is very important, that you have the children with and the offspring of 1 or 2 generations with the same disease. Just if you didn't see Marfan, 1896, he discovered the 5-year-old with a hereditary disorder. The word hereditary means he went into the history, and a good doctor will always go into the history details, and as pediatricians, we take a lot of history. I know adult cardiologists don't have time, but I think if you have the time, especially, and also as a fetal cardiologist, we talk a lot with the parents. History is very important in diagnosis. Marfan syndrome, you all know better than me, and we know that these are tall, and then the ratio between the upper and the arms and the upper and lower body is different. And incidence is 1 in 3,000 to 5,000. And there is no ethnicity or race, and this is very important in this genetics. We know that lots of mutations. So what does mutations mean? It means that you cannot diagnose a disease without having an index case. So you have to have a member in the family with Marfan, and then you can check the rest of the family. So this is the index case. So the mutation is FBN1 mutation and has been identified in 90%. Mutation in a gene means that the gene was okay, but something abnormal happened and it got mutated. So this is de novo mutation. It happens like that randomly. Now, in 75% of patients, we have autosomal dominant. So Marfan is autosomal dominant. So you counsel saying that if you get married, it's 1 in 2 chances with every child that this will be a Marfan syndrome, okay? Plus the features. Usually we depend not on the features nowadays, we depend on genetic testing most of the time. And 25% is mutation. So as we said, mutation, simply mother and father are normal. Though it's not carrying the gene from the mother, this is a mutation at a cellular level. The first fibrin gene mutation was identified in 1990. So now we don't go clinical a lot, we go more on genetic testing. So we said that this is the gene and so on. Pathophysiology, you don't need to know a lot of that, but we know that there's cystic medial necrosis. The word medial is very important in Marfan syndrome. Medial necrosis, the layer that is involved in it is very important, and this is a predisposition to dissection that happens in the carctation or in the aortic dilation later on. Okay, now ectopia lentis syndrome. So not everybody with dislodged lens is a Marfan syndrome. We have other things. You have to do genetic testing. And this is a Marfan. So if you look here, you find that the hands are, I mean, if you look the ratio of the hands extended will be equal to the ratio from the head to the symphysis pubis, which is not the usual thing. And when you ask them to put their hands down, you find that the hand is reaching to the mid-thigh, okay? And this is the hyperelasticity. So not everybody can do that, is a Marfan syndrome. Now, you have to have, as you said, index case and so on. And clues to diagnosis, family history, but remember there's something called de novo, and then you check the heart, and if you find that there's also Marfanoid syndromes. So not everyone who is aortic root dilation is a Marfan, or abnormal upper to lower body ratio is a Marfan. Go by genetics. So aortic disease, dilation of the aorta, and this is very important in pediatrics. When we see them, we give them a number, and then we put them in beta blockers before we hand them over to you. So this is a sort of aneurysm that can happen. As we say, cystic medial necrosis is behind this abnormal anatomy. And the frequency of Marfan syndrome is responsible for aortic dissection. This is very important. 50% of those under 40. So you have 50%. When you have aortic dissection below 40, think of Marfan syndrome. If you didn't know the story, 50%. 2% of those age 40 to 70, and over 70, Rabbina rahamhum. They don't have it, it seems. Okay, just a dissection. And this is just to remind you, we don't see this in pediatrics a lot. Oops, I'm almost done. Just give me a few seconds, please. Can you?
Okay, 5 seconds.
Excuse me, doctor. You can
5.5. Okay, so I'm not going to go through this, but I'm going to take you to my beloved, this is the bicuspid aortic valve. So we'll talk about aorta and then the bicuspid aortic valve and the type of bicuspid valves and so on. And this is the MRI of bicuspid aortic valve. And of course, there are lots of modalities trying to see when will you get, this is another MRI, advanced MRI techniques that they do with flow hemodynamics, and you want to diagnose it. Coarctation is very important. This is now aortopathy. And we diagnose this as being a fetal cardiologist. We diagnose it starting from 14 weeks onwards. We see that there is a sort of narrowing, but as a fetal cardiologist, it's one of the most difficult diseases, and you can easily miss postnatally. And then as children, they die at home if not diagnosed. So it's very important to have antenatal diagnosis of coarctation, because they will look normal at birth because there is something called ductus arteriosus. There will not be difference between upper and lower limbs.
Dr. Rima, I think we have really to stop here. Thank you very much.
La 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 la.
La 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 la. We have really
Let
to
me
stop
show
here.
you one fetal, so just one fetal, please.
لا 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 خلاص دكتورة والله عن جد. We
Just a
will
second.
take 1 minute.
Just a second. This is a fetal case of tetralogy of Fallot. This is the overriding aorta, and this is the VSD. And as you know, tetralogy of Fallot is one of the diseases that can cause aortic duct dilation postnatal. This is transposition of great arteries in utero. And also, when we do the Ross, this is one of the causes of aortic root dilation. And thank you so much.
Our next speaker is Dr. Zakaria Almoosa. Zakaria, 12 minutes, please. With the role of echo in post-repair congenital heart disease.
Thank you again for the invitation. So thank you, Dr. Rima, because you give some change of mood before I go into my talk. So we are continuing in the congenital heart disease echo. So commonly, like what Dr. Rima said, that these patients will come to you as an adult cardiologist, either repaired or de novo. I would say nowadays more common to see the repaired congenital heart disease in adults. And I do believe that should be a combined service between the adult and pediatric cardiology, because they are complementing each other. And we learn from each other when we manage these patients. So I know that mostly the pediatrician are the one who is dealing with this patient. They are really excellent. But still, I see a role for adult cardiologists to be involved in these patients. So remember, the repaired complex congenital heart disease are not cured. They are repaired. They will come to you with long-term complication of their early surgeries. And that's why we are in adult congenital heart disease, we're talking about 20 years outcome, 25 years outcomes, because these patients, they were prepared early in childhood, and they will come later on to you with a late complication of their surgeries. So as another cardiologist, the most difficult for us is to understand the native anatomy, and then to understand the type of repair. And this needs a lot of exercise. You need to have some imagination of this complex congenital heart disease. So because of the matter of time, I will concentrate on two topics. tetralogy of Fallot and transposition of the great artery. So we'll go quickly over some of the basics. So we know that tetralogy of Fallot, the basic anatomy is the overriding aorta, subaortic VSD, RVOT obstruction, and RVH. Now, the RVOT obstruction determines the clinic TET. However, on the other hand, the other spectrum is the severe RVOT obstruction to the point of pulmonary atresia, and they will present very early in childhood. The infundibular hypertrophy progresses with time, and with age, the cyanosis will increase and they will present. That's why early in the early era, their presentation for tetralogy of Fallot was not very early in not the first month, not maybe in 6 months of age. They will present later in their life. Remember, any congenital heart disease patient, they have associated anomalies. So you have to look and exercise to look for these associated abnormalities, like BA and tetralogy of Fallot, specifically PA, branch BA stenosis, right aortic arch in 25%, anomalous coronary arteries, where the LAD come from the RCA. This has an important, let's say, decision-making in their adulthood when they come for percutaneous pulmonary valve replacement. If the LAD cross the RVOT, and you are planning to implement a pulmonary valve, the LAD will be at risk of compression, and that might change your management plan. ASD, BDA, pulmonary, partially anomalous pulmonary vein return, and aortopulmonary windows are also common associated with tetralogy of Fallot. Now, early in childhood, they will go into palliative systemic pulmonary shunt, like the classical is the BT shunt, or nowadays it's called BTT shunt, which is left subclavian to LPA shunt, and the others is the POTS and the Waterstone shunt. Ultimately, their surgical correction will be either with symbol, which can be including the resect of the RVOT muscle, closing the VSD, and pulmonary valvotomy. Other more complex surgical repair include the RVOT patch, transannular patch, excision of the pulmonary valve, and in severe pulmonary RVOT obstruction or the PA atresia, you might need RV2PA conduit. So understanding, as I said, understanding these, the native and the surgery will determine the late complication, and it will determine what you should look for in your clinic or in your echo. So some of these complications, or let's say the most common complication, late complication, including the residual lesions like VSD, BS or sub-BS, branch BA stenosis. Pulmonary regurgitation is very common, and ultimately the RV dilatation and dysfunction, LV dysfunction, aortic dilatation and regurgitation, arrhythmia, and sudden cardiac death. So, for echo, is the common question or the common scenario is to find a pulmonary regurgitation. And most of the time, you will find a laminar flow with the color where you might miss it, easily to be missed because of the laminar flow. It progresses over decades, and it cause a volume overload in the RV, and ultimately they will come with severe RV dilatation and dysfunction. So with the color, as a rule, if the BR is in the mid BA, this is moderate pulmonary regurgitation. If the flow reversal, if the flow reversal, diastolic flow reversal, reach the branch BA, this is a severe pulmonary regurgitation. The other indicative of severity of the PR is the continuous wave Doppler. If there is rapid deceleration time and the envelope ends before the end of diastole, this is indicative of severe pulmonary regurgitation. As I said, severe PR will lead to severe RV dilatation. The severe RV dilatation and dysfunction will cause over a long time secondary LV dysfunction. The progressive RV dilatation will lead to increase the QRS duration, and this will put this patient into higher risk of sudden cardiac death. And like what we see in this ECG, that it is a wide QRS duration. So what are the indications for the BVR in asymptomatic patients? So the indication of BVR in post-TOF class 1 is a symptomatic patient. What about asymptomatic patient? The guidelines stated that mild to moderate RV or LV systolic dysfunction, severe RV dilatation by MRI, where the RV in diastolic volume index more than 160 ml per meter square, or the systolic volume index more than 80 ml per meter square, or the RV in diastolic volume more than 2 of LV in diastolic volume. Elevated RV speed due to RVT obstruction more than 2/3 of systemic, progressive reduction in exercise tolerance. Now, is the MR the only tool to assess the RV in diastolic volume? There is one paper which I use frequently in my echo lab, came from Toronto, showing this equation of RV in diastolic area divided by the body surface area multiplied by 7 plus 11.5. It correlates very well with the CMR volume. And myself, I am practicing it frequently. Like in this patient, I calculated the RV in diastolic volume. I got 133 ml per meter square, and the MRI got 140. So in my practice, the difference is something like 5 to 10 ml. I use it very frequently. I get used to it. I'm practicing it, so I have a good experience. I hope that also you practice it. But it's only for the end-diastolic volume, not the end-systolic volume. And it's limited to tetralogy of Fallot. I cannot extrapolate it for severe PR for any other reason. Part of your assessment with the severe, with tetralogy of Fallot, the RV systolic function, which include the TAPSI and maybe the tissue Doppler, and then moving to the other, let's say, repair, which is the Rastelli repair, which include closing the VSD with the patch and putting a conduit from the RV to the PA. However, as you can expect and predict, these babies, they have a small, they are growing and the conduit will stay the same. So they are at risk of conduit stenosis and they will require multiple surgeries, redo surgeries for the conduit replacement. This puts them into at risk of the ventricular arrhythmias, VSD patch and leak and dehiscence, and unfortunately they are at higher risk of sudden cardiac death. Now this conduit, if you want to assess it with echo, they are very anterior. So they are anterior to the RV, and it might be difficult for us in echo lab to evaluate and to assess. So you have to have a good angulation to get this flow or to visualize the conduit with color and then with the continuous wave Doppler. You will find that they have severe RVH and RV dilatation because of the high gradient over a long period of time. Moving to the next anomalies or the next disease, which is the complete transposition of the great arteries. Remember the original anatomy, the systemic venous flow will come to the right side, it will go to the aorta, and the pulmonary venous flow will come to the LV and it will go to the BA. So there are two parallel circulations. This is incompatible with life. They usually present in the end of first week of life because they have a persistent foramen ovale which cause the shunt, right to left shunt, or a patent BDA, patent ductus. If they close, they will present by end of the first week. That's why they need emergency septostomy or Rashkind atrial balloon septostomy. So eventually they will end up with one of three surgical repair. Initially, atrial switch, or what we call it sinning and or mustard. The golden nowadays is the rule, the standard is the arterial switch, and some of the patients will end up with the Stanley-Reich, the tetralogy of Fallot with PA atresia. Senning is a Swedish surgeon who was working in Zurich. He invented this procedure in 1958 with atrial tissue. He was using the septal tissue to create the baffle. And William Mustard is another professor of cardiac surgery in Toronto General Hospital. He corrected that surgery with, he did the surgery with synthetic material. So basically, they have the same concept by baffling the systemic flow into the left side of the left ventricle from the SVC and the IVC, and baffling the the pulmonary flow into the RV. So, okay, I need only maybe 1 minute. Okay, so it is a physiological repair, but not anatomical repair. So the RV will work as a systemic ventricle. The tricuspid valve will be the AV, the systemic AV valve. Long-term complications including RV dysfunction, severe TR, atrial arrhythmias, baffle obstruction, baffle leak, pulmonary hypertension, and by the 4th decade of their life, most of them, they will need heart transplantation. By echo, if they are functioning well, you will find that the LV is squashed, and it's usually D-shaped, smallish, it is pushed by the dilated RV. This is a very normal for these patients. If you find a rounded LV, you should raise your suspicion for baffle leak. Now, but you can, this is the 4-chamber. Remember, just to not to confuse you, because TGA is always a confusion in the adult population. Complete TGA has both ventricle, both atria are in the same. The problem is in the arteries, in the great arteries. So in here, that is the left ventricle, and this is the right ventricle, and this is the right atrium, this is the left atrium. You can see that the left atrium is very crowded with the baffle because it has the systemic venous baffle and the pulmonary venous baffle. And in this patient particularly, you can see an ICD lead in the left ventricle. Yeah, so you can assess the baffle by flow, by color flow. That was the systemic venous baffle flowing into the left ventricle, you can see. And then the pulmonary baffle, I have only, okay, almost done. I have only 2 slides. Two slides, please. I need to finish as well. I hope the audience are enjoying my talk and they will give me a chance to complete my talk. So if you are in doubt, I just want to show you, if you are in doubt with this patient, use a simple technique, which is the bubble. This will identify for you the RV and the LV, and it will show you if there is any leak, especially like here, for example. Do you see the leak? That's the leak from the systemic venous valve to the RV. Lastly is the arterial switch, which is the anatomical and physiological repair invented by Adib Jatain. He is a Brazilian surgeon with Lebanese origin. It looks very good. However, the long-term complication including the PA stenosis, neo-aortic regurgitation, neo-aortic root dilatation, coronary stenosis, and unfortunately they are at risk of sudden death. Still, we are learning from these patients because they are relatively young. It was invented it was widely used in the 80s, and in the 90s now, it is the rule. Rastelli procedure is the same like what we mentioned in the tetralogy of Fallot. So the take-home message, congenital heart surgeries are repair, not cure. understand the native anatomy and the type of the repair, echo play a major role in managing these patients, and collaborative work between adult and pediatric cardiologists is mandated in this patient. Thank you.
Okay, thank you, Zakaria. Now, Amy, she's well known. She is consultant cardiologist, echocardiographer. Talk about the role of echo in circulatory support devices.
من جد والله أنا حابة أشكركم واحد يعني اللي جلس لهذا الوقت for the last lecture of the day. Thank you so much, and thank you Dr. Ala حقيقة for making this again happening, seeing the faces that we missed for a long time. So يعطيكم العافية وجزاكم الله خير. I think my talk is totally يعني another direction of gear بعد congenital and Dr. Rima's talk. So we'll touch base على the role of echo in circulatory support. And I'm not sure if this is commonly in most of the cardiac centers now using the mechanical circulatory support. So echo lab in these centers may benefit from this talk. So we'll try to touch base on the indication, what's the available devices, and what's the role of echo pre, during, and post implantation. I just want to highlight, this is the guidelines in the American Society of Echo website, and this guidelines was published in 2015. So it's not new anymore. Like, since the publishing of these guidelines, there is not much of a change in terms of parameter. The change is in the new device modalities themselves. And when these guidelines came out, it was actually presented to the American Society of Echo, and it was already late presentation in the Western society because they started in mechanical circulatory support way before the guidelines get out. So as we know, mechanical circulatory support devices came to the market because of heart failure patients. So we know that we have a large population of patients in the cardiology, chronic, a lot of comorbidities and mortalities related to them are heart failure patients. And with the advanced heart failure patient therapy, we know that there are a group of patients who will not respond to the optimum medical therapy, and they will need to have more in terms of mechanical therapy. Heart transplant in the other arm is not available for all patients, and the number, although it started to increase, we still didn't really see the great light from the heart transplant in terms of treating heart failure patients. So we end up by discussing and studying the mechanical circulatory supports as a bridge to transplant or a bridge to recovery in certain cases like myocarditis, Takasupu, or post-shock, or even destination to therapy, who patient doesn't fit for transplant, they are refractory, rate of hospitalization is really demanding, and you really want to help them. So what are devices available in the market? We do have left ventricle devices and right ventricle devices. And if you want to really divide them, there are many classifications for the division, either due to the flow itself. So we have the axial and the centrifugal. We have the intracorporeal and the extracorporeal. And the way I like it, because that's really the function we go over it, is the short term and the long term. So we do have the long-term devices, which is the LVADs or RVADs, like HeartMate and HeartWare. And we have the short-term, which is commonly now used even in the cath lab, inserted, like the Embella and the intra-aortic balloon pump and the ECMO. So let's start with the LVAD. Very important to understand, it's a continuous axial flow, and it's designated actually to minimize the operative risk and to give a better durability and improve the patient clinical outcome and quality of life. So it's very important to look at how the device is formed. And the device is having an inflow cannula, which is connected to the LV. And then you do have the controller, which is the impeller. And then there is an outflow cannula or a graft, which anastomoses to the aorta, basically in the ascending aorta, which is, that's the outflow track that you have to graft it, and that will go to the aorta. So that's basically the cycle. LV to the inflow through the apex, then you have the impeller, and then the outflow graft to the ascending aorta, and then to the aorta and to continue the circulation. Now, how echo can really assess that? So echo has basically 4 roles. We'll start with the first role, with the pre-implantation. And this is depend on the patient selection. Now, we do have transthoracic and transesophageal. Transthoracic is the first line in this group of patients. It detects, it confirms the systolic dysfunction. It will help you to screen patients and candidates to rule out the contraindication. And if the transthoracic is not really optimum and you are struggling with the imaging or you need more information, transesophageal here can come to the consideration, and it will be very helpful. Now, the exam protocol, I will show you how the guidelines really summarize this protocol, but it's very important to cover all the elements in assessing patient with heart failure and to have a very special attention to the red flags, which are the contraindication. After the first line imaging modality, then we will have the performance, supervision, and the interpretation of the echo. And here where echocardiographer and the sonographer, both of them, has to have a back knowledge of what is really mechanical circulatory support in terms of echo. So it's very important to have a document or a reference to go back and to have more educational in terms of that. So what we assess in our first line echo, we assess LV-RV function, dimension, size, and volume, and then we look at the valvular function, particularly the aortic valve, and also we try to rule out clots, thrombus, and shunt. So these are the red flags, and I will consider this the most important slide in the presentation, actually, because you have really to know this, and if you forget the other, they will come with any routine echo. So what are the red flags that we have to look at for any mechanical circulatory support that needed an echo? First, look at the left ventricle. Left ventricle should not be small in size. So if the ventricle is small, that will really be a problem with the suction events of the machine. So you have to assess the size. You have to rule out thrombus, apical aneurysm, or a presence of any shunt. So that's the first important chamber to evaluate. Then the right ventricle dilatation, right ventricle dysfunction. This has to be reported before going for LVAD. You may change your decision and make the surgeon, instead of putting one, to put a biventricular assess device. And then we have to rule out thrombus in the appendage and presence of any atrial shunt, like a PFO. And here we may need a transesophageal echo basically for that. And then we move to the valve. And when we talk about the valve abnormality as a red flag for the mechanical circulatory support, remember, prostatic valve, so mechanical, so an aortic or mitral, will be a contraindication. So if that patient really want to go for an LVAD, they may change the valve from a prostatic mechanical to a bioprostatic. Any aortic regurg more than mild is not going to be acceptable. So remember, aortic regurg with an LVAD, they don't come together. Moderate MS, moderate TR, mild TS, mild PS, moderate PR, any mobile lesion on the valve in terms of endocarditis or thrombus or any mobile mass, that will be a contraindication. You have to deal with those before you address that patient for an LVAD. And then look at other, like congenital heart diseases, and it's very nice to have a great talk with Prof. Rima and Dr. Zakaria. Aortopathies, like aneurysm, dissection, atheroma, coarctation, and any shunt. So remember, it's shunt, AR, and thrombus, if we really want to summarize it and not to forget it as a red flag for LV mechanical circulatory support. RV function, again, very important note. Of course, all of us, we use this modality to assess RV function. We use the fraction area change, the TAPSI, and the lateral annulus and the tissue Doppler for the S prime. But what I really want you to take a message here, that if the fraction area change is less than 20%, this will be a risk of failure. So this patient will not go for an LVAD, he will go for an LV and RV ventricular assess device. Aortic regurg, again, remember, the LVAD will not function with the aortic regurg. Why? You are basically closing the loop. You are making a blind flow loop. The LV will give to the LVAD will get to the aorta, it will come back to the LV. So you're not getting the flow through the aorta because it's coming back through that AI to the LV. So that's a blind loop which we should not have it. I'm demonstrating here a case where a patient who have an AI who should go for an LVAD. So what did they do? They did what they call it the central cooptation stitch. They stitched the central cooptation zone of the aortic cusps, as you can see here in the short axis, to minimize the aortic regurg. What's the downside of this? The downside of this is that if the LVAD fail, there is no opening gate for the outflow or the outward volume. Now, AI can be challenging in heart failure patient. Why? Because we know this patient already have a low stroke volume. We know that they will have a low systemic and high diastolic pressure, so that may underestimate the severity of aortic regurg. So you have really to be careful when we report aortic regurg in terms of selection for LVAD. Shunt, I'm putting this as a single slide to remember those. So shunt, again, is not acceptable. You are basically contaminating the loop. So any intraatrial shunt or interventricular shunt. What has been noted and reported in 40% of LVAD patients that PFO is usually masked in patient who is selected for LVAD. And the device failed because of the PFO was not diagnosed. So you have really to use all modality of bubble, transesophageal to unmask the intracardiac shunt. Now that's before the implantation. Now going to the perioperative, we usually use a transesophageal echo. Of course, we rule out the red flags, and then we start to assess in the function, what's the really size change in the left ventricle, what is the velocity of the inflow cannula. Now, what is the inflow cannula? It's here in the apex. So if you really measure that by Doppler, it should not exceed the normal inflow that indicate no obstruction, which is 1.5, right? So we will report anything more than 2 centimeters per second as an abnormal. Same thing for the outflow cannula, which is the anastomosis with the ascending aorta. This is a very tricky, so in transesophageal echo, you really have to have a little bit of an upper esophageal view using the ascending aorta view in order to visualize the anastomosis of the graft and then try to pulse it. Now, some patients may really have an interfering forward flow, either from a mitral valve or from aortic valve. So you have really to be careful in measuring the Doppler velocity of the inflow and the outflow. As I said, aortic valve opening is important to measure. You want the valve to open. You don't want it to open more frequent. You don't want it to open long, but you want it to open because that's the only gate. If the device fails, the ventricle will be able to eject a forward flow. And again, assess AR severity, RV function and size, similar to the LV function. Now moving, this is a case that was done using a transesophageal echo, so you can see the inflow cannula, very nicely see in a 3D, and that's the outflow graft, which is the anastomosis with the ascending aorta. Now, time will not help me. أنا لبعد ولا المايك بعد؟ طيب. Time will not help me, but just to show you, in the outflow graft sometimes would look like a flow adjacent to the right side. So don't get overwhelmed. What is this flow? This is the outflow graft. And sometimes they report this as a pericardial effusion, and that's wrong. It's not a pericardial effusion. It's an outflow graft, exactly. So when you put a color, you will see it. If the color was really sluggish outflow, put a Doppler, and you will be able to measure it. Look carefully for AI and unmasked PFO. That's for the preoperative transesophageal echo. Now, one of the important things that we use is the speed. An echo helps the group of the intervention to adjust the speed. So if the device is going on a minimum speed, of course you will notice that clinically with low blood pressure, patient is congested, you're not really getting any improvement. Looking at the echo, you will see the diameter or the dimension of the LV will start to increase and the septum will start to be shifted rightward. So then you know that your device is not on the accurate speed. What if the speed is maximum? It will be the opposite immediately. Septum will be shifted toward the left, and you will see the suction events of the left ventricle with the cavity is at a smaller size. And if there is an AI, you will see that the AI is increasing. So echo really, before you getting the probe out, can help the intervention and the surgeon to inform them if this is, أخذ 1 minute? Okay, to inform them if this is the appropriate speed or not. That's my images is frozen. So next I will talk about is the post-op echo and how can the post-operative transthoracic echo help us. So 3 views you have to remember: parasternal long axis, M mode on the aortic valve, and apical view. That's your protocol for the post-op LVAD imaging. Why we need the parasternal long axis? For the RV, LV sizing, for the aortic valve and ruling out AI, and if we were able to visualize the outflow graft. Why I need the M mode of the aortic valve? Because here I have to check really the closure and the opening and measure the duration. Why I need the apical view? Because in the apical view, I will see the inflow graft and I will be able to pulse it and get a Doppler assessment. The apical view, the only problem with that is artifact from the device. So sometimes you don't get the best view for color Doppler, but you will be able to do a spectral Doppler. Surveillance of the optimization has to go from the time of discharge, 1 month, 3 months, 6 months, 12 months, and then after that, every 6 to 12 months. Very nice summary in the guidelines. Anyone can establish these protocols for the surveillance, for the optimization, and even there is a spreadsheet that you can use it and adapt it in your EcoLab in order to help remembering these parameters. I'm done with the LVAD, and if I have a minute, I will go over the Ambella. So this is just an example to show you aortic root thrombosis that cause a significant AI and obstruction of the outflow graft. And I want to go to the short-term mechanical, which is the Ambella. I'm not sure how commonly your lab is seeing a patient with Ambella, but we start really to see it very commonly from our cath lab and intervention group. It's a small mini device of circulatory support, catheter-based, going from the femoral to the LVOT. And what really I want you to memorize for Ambella, that there is an outlet area, and then you see the device shaft and the inlet area. Why this is important to remember, when you look at the echo, this is what you will see. So this has to be beyond the aortic valve, at the level of the aortic valve cusp, and this has to be in the mid-cavity, not interfering with the mitral apparatus. And this is the message that I want you to really take home, that this is the proper position of the Ambella. Last week, we had an Ambella inserted in the cath lab. I will show you the image of that Ambella. But you see, that's the cusp, and this is where you really have the outlet, and this is where you have the inlet. And if you put a color, you will see the color in the distal flow. You can visualize it in the short axis, but the recommended view is the parasternal long axis. Last image before I finish, I just want to play this. So these two cases done, the same patient, The same patient in the cath lab. So this is initially where you can see the shaft of the Ambella is interfering with the mitral apparatus and actually adjacent to the posterior wall, where it has really to be free in the LV cavity. So it's very important to visualize the length of the shaft, and it has to be from 3.5 to 4 centimeter from the aortic annulus toward the LV cavity, not interfering with the mitral valve or the mitral apparatus. With that, I finish. Thank you so much. And if there is anything I can add.
Really, we enjoyed. Sorry. Okay. Really, we enjoyed this conference, and I feel all of the attendees already enjoyed this also. I would like to thank all who already stayed for this late time with us here. And I hope, inshallah, in the next conference to gather the same group again, inshallah, here, but will take longer time because of shortage of the time. Really, we canceled today the most important thing, which is the Jubardi. And really, I'm very sad for this, but the problem, there is no enough teams, and also we are committed for the traveling also for the people. They have to travel now, and there is no time. So we apologize for this. And lastly, wanted to all come here for a group photo before we go. And thank you for attendance. Allah يبارك فيك.